Hello, good morning, one and all. We'll be waiting for participants for the next 5 minutes and then we can start the meeting. Please bear with us for the time being. Thank you. Hello. Hello, very good morning to all the speakers in the room here. A very warm welcome. As we participants are late to join, I think we start as we have already passed the presentation time. So thank you for bearing us. Very thank you. And also, myself, Josh Geoshot, and on behalf of this conference, I'll be moderating the first session. So, it gives me immense pleasure to invite you to the Global Summit on Breast and Women's Cancer. That being said, I would now like to call upon our first speaker, Dr. Özge Çelik from Adnan Menderes University, Turkey, to deliver her keynote speech on should exosomes be used in diagnosis or treatment in gynecological cancer. Hello, doctor. A very warm welcome to you. Hello. Okay. You can start your presentation, doctor. I think the participants will be joining us shortly.
Okay, thank you so much. Good morning, everyone. First of all, I would like to thank the Congress Organization Committee and the participants. Today, I will talk about the studies that we have done in our laboratory on exosomes and their role in surrogate treatments. And make a presentation. I am a professor in Aydın Adnan Menderes University. Generally, I am studying in exosomes therapy, exosomes drug delivery systems. Today, my presentation is should exosomes be used in diagnosis or treatment in gynecological cancers? Exosomes is a different natural biocarrier for us. Exosomes is small nanoparticles, is natural nanoparticles. Generally, all of our cells is produced exosomes. More and more than studies shown that exosomes can regulate a variety of the biological function because there is an exosome traffic between in our cells, in the microenvironment of the cells. As long as there are the cells that produce exosomes and the cells that uses the exosomes, this traffic continues until the end of the life. In exosomes, okay, what are the exosomes? What is the structure? What is the including to the materials? Exosomes, a class of small Blair vesicles derived from virtually all the eukaryotic cells, have been exploited as a promising natural delivery platform due to their low toxicity, excellent structural stability, nanoscale size, cargo loading ability, and surface structure is modifying is very useful. To load the therapeutic or diagnostic cargoes. For example, drugs, nucleic acids, proteins, peptides, or another nanomaterials into the exosomes. The multiple techniques using the developing the exosomes therapy, such as incubating the cargoes with exosomes or exosome secreting cells, transfection or physical treatment, sonication, electroporation, extrusion, freeze and thaw, surfactant treatment, and dialysis, many things. The biogenesis is contents and functions of the natural exosomes and provide the comprehensive discussion for the strategies of exosomal cargo loading, the membrane and modification for targeting therapy. Exosomes have some tetrapenins and surface marker. This is important for us. When we are isolating to the exosomes, we are using this one. This information is important for exosome isolation. And what is the structure of the exosomes? Exosomes is share the many conserved cargo composition. Protein, DNA, mRNAs, and carbohydrates, lipids, many things. Secreting the cell type and it is microenvironment is the importance for this situation. This rich contents of the exosomes is very important for both from diagnostic point of the view and from the therapeutic point of the view. For example, many studies show that mRNAs and cytokines in its content may even cause the one set of some disease. Recent clinical studies on this subject emphasize that exosomes contents should be investigated in more detail. Many laboratories, Europe and USA and other countries is studying the exosomes, and exosomes is what is the including the exosomes materials. Firstly, we have to be isolated to the exosomes whenever diagnosing or therapeutics. Exosome separation techniques is the difference. Size exclusion chromatography, ultrafiltration, ultracentrifugation, immunoaffinity, precipitation, microfluidic systems. These techniques is presents advantage or disadvantage depending on the sample and required amount. Although ultracentrifugation techniques is the gold standard in all of the world, there are disadvantages owing to the high cost of the required instrumentation and the long extraction time and another manipulation is sometimes problem, but gold standard is ultracentrifugation methods. Size exclusion chromatography is widely used to isolate the high quality exosomes, minimize the damage the exosomes. However, size exclusion is preferred for industrial exosomes production because the large size of the columns used to cause few restrictive problems. Another ultracentrifugation, while the ultrafiltration is widely used in the isolation of the exosomes from body fluids, given that it is the deal and fast for large volumes of samples. However, the extraction efficiency of the exosomal isolation is lowered because generally filter is the clogging. This is the problem for us. In immunoaffinity capture is techniques is the useful, but exosomes are the captured without specific antibodies, aptamers, recombinant protein, or you have to use to some things because you need the immobilization methods. You have to immobilize on the matrix, and subsequently collected with the help of magnetic beads or agarose beads. You can use that, but a little bit expensive for the exosome isolation. Due to high sensitivity of this approach, it is widely used in diagnostic studies, but it is, however, not suitable when the sample volume of the large. You can using the minimal sample, 200 microliter between 500 microliter. Isolation kits is entail the use of the polymers, the significant hydrophilic properties that allow the passage of exosomes to a hydrophobic microenvironment. However, the problem of the proteins often encountered this approach. Future exosome isolation methods is changing now. Microfluidic based exosome isolation is the popular, and many studies is going to this way. And in our laboratory, we are studying the in exosome isolation in microfluidic systems. Two microfluidic systems have passive microfluidic isolation methods or active microfluidic methods. If you are using the passive microfluidic isolation methods, include the filtration, internal focusing, immunoaffinity, lateral displacement, and viscoelastic flow. And active micro-isolation methods is the important in we focusing in this area. Acoustic and the electrophoretic isolation methods is the important. You are producing some microchips on some new methodology. And microfluidic devices can be used to create the microenvironments that mimic those found in the body, which can be useful for this study mechanism and the effective of the potential therapies. Microfluidic is important for biological and medical studies because it allows for precise control and manipulation of small fluid volumes. And this platform is high efficiency and potentially allows for high throughput isolation of the exosomes with minimal sample of loss, while also providing a high degree of utility. This can be especially useful for basic research and drug discovery, as well as for the clinical application, such as diagnostic and therapeutics. They have some advantage or disadvantage. Sometimes we are comparing which is the perfect for us. In general, passive microfluidic exosome isolation methods are simpler in terms of the required peripheral equipment and user expertise. On the other hand, passive methods don't not allow the dynamic control that active isolation methods is the offer. Now, active isolation methods is the popular. The medical potential of the exosomes is mainly includes the three major directions. Potentially of exosomes is diagnostic prevention, medical potential of the exosomes, and drug delivery potential of the exosomes. Diagnostic is exosomes extracted from the case microenvironment can be used as the biomarkers for diagnostic of specific disease and injuries. In medical potential, exosomes are produced a variety of cells and interact with the targeted cells in various ways to how to produce and medical effects and targeting including the many information. Drug delivery potential of the exosomes. Exosomes can be used to deliver a variety of the drugs such as DNA, RNA, all small molecules. This is the usual. We focusing in our laboratory in drug delivery exosome potential of the exosomes. Diagnostic in the expectation for the exosomes are drug carrying is rooted in the unique structure of the exosomes. Because the outside is the membrane composition is phospholipid layer, and the membrane is the rich protein. And inside some cavity, you can using with some micromolecules and small molecules and nucleic acid with quantification this one. This cavity is a space we can use for the drug delivery. The extent of the external proteins is the very variable. On the it is low immunogenicity and repeatable administration is the important for the exosomes drug delivery. And on the other hand, these proteins can be used for surface modification and loading the micromolecules and improving the targeting. These exosomes is potential for drug delivery system. What do we know about the exosomes since the cancer cells? We know cancer cells produce more exosomes, and cancer cells more metabolic activity than normal cells, and more access the cellular waste. And this may happen because they more metabolic activity than normal cells, because they generate all the time the extracellular waste. With our understanding of the core of the proteomic now, we are able to compare the exosomes from cancer cells and from those normal cells and learn that what is the unity of the cancer exosomes. There are a number of the proteins being identified that seem to particularly inherent in cancer exosomes. This important because we can use these markers to determine if an exosome comes from the cancer cell or normal cells, then perhaps even what tissue it's originated from. And many studies on exosomes and their biological function have improved the understanding of the intracellular communication of exosomes in different cells. These nanoscale vesicles are active carriers and regulatory information of biological macromolecules can be further induced and regulated by the receptor cells, the main cells type, including, for example, fibroblasts, endothelial cells that interact with the cancer cells. We can learning the tumor microenvironments, all of the information from this one. The exosomes is included the different proteins, and cancer exosomes more integrated than other cells. And cancer exosomes involve information of metastatic lesion. We can know this one with omic studies. It can help to this information. Exosome and diagnostic. How we can use the exosomes to benefit the patients. The exosome approach to a biomarker discovery and development has distinct advantage over other liquid biopsy methods like ctDNA or CTC. Exosomes are the platform of find the clinical utility in diverse disease areas, including and oncology, neurodegenerative disorders, cardiology, immunology, information. You can analyze the DNA, RNA, and protein structure from exosomes. Profile the enter the transcriptome. Generally, RNA sequencing is the most popular for exosome quantification. And potential use of the exosomes as liquid biopsy in the cancer. Liquid biopsy are non-invasive, can be obtained serially. And this is so traditional methods, and may facilitate early cancer detection with the cancer derived exosomes. If you are collecting the microenvironment or some liquids, you can be detecting non-invasive, and it can be so useful. Now in our hospital and many hospitals using these methods, cancer derived exosomes as biomarkers because of early cancer detection is promising science. Exosomes could reveal genetic or phenotypic alteration in the cancer. What can be analyzed in exosomes liquid biopsy? Exosomal proteins and potential for biomarkers for cancer. Exosomal mRNA is potential, and other exosomal components is potential biomarkers. Now, many laboratories are studying this one. How we will using this one the treatment strategy. If you want to use for the treatment of these exosomes, you need you have to load into the cargos or into the exosomes. There are two main strategies: passive cargo loading or active cargo loading. Drug loading after passive cargo, drug loading after exosome separation. This strategy is required the preserving the structure and the function of vesicles. Active cargo loading drugs by adding the manipulation of the exosomes, donor cells prior to the exosome separation. This strategy requires the compatibility and stability parent cells with drugs to be encapsulated in the exosomes. They have some particles or metallic ions, and you can reducing within the exosomes. What do you want to? What is your target? What is your strategy? You can choose these loading parameters. The strategy is for preparing the targeted exosomes. To obtain targeting capacity, homing the molecules are assembled on exosomal membrane via transfection and the chemical modification. And homing molecules called the exosomes are quite the targeted as ligand, receptor binding, pH gradient, electrical attraction, or magnetic field. We work in our laboratory, especially modified the exosomes for drug loading and functionization. And we are using the electrophoretic techniques in our laboratory for drug loading. Are there clinical studies in exosomes? If you are looking for in the studies, today published preclinical studies of the exosomes drug delivery system are only in mice, rats, or zebrafish. Only research article we have. Pig have been used the preclinical test for the exosome therapy, but does not drug delivery systems is not published or not approved non-human primates. In November 2022, and FDA has accepted Brixygen's phase 1 clinical trial initiation, the exosome-based therapy treatment for atopic dermatitis, but this therapy is not combining the drug delivery system, only exosome-based direct exosome therapy is the used this approved. And we are schematic presentation for the exosomes as the DSD in preclinical animal models. You can collecting the exosomes, and exosomes is included to the many things, and you can give it to the this one oral, intranasal, IVD, intraperitoneal, and subcutaneous injection. This one after you have been collecting to the tissue and blood and urine. After we can go to the C parts for human studies and human related studies. We now in preclinical studies in the exosome-based therapy. The pharmaceutical industry is widely uses the liposomes to deliver the drug into the cells. Liposomes and exosome is the similar. Exosome is the natural, liposome is the productive. Liposome have our advantage, and exosomes have the more advantage because this is the biocompatibility and non-inflammation. Exosomes, protein hydrophilic threads, nucleic acids, mRNA, cRNA, mRNA, miRNA can be loaded into the lumens of the vesicles, while the targeted ligands, membrane proteins, and lipophilic drugs can be incorporated into the membrane. Now, generally, we are using some drug delivery system in pegylated liposomes or liposomes and comparing to the extracellular vesicles. And in my laboratory, my team had published more papers. I will explain to some things from our studies. And first of all, in my master students' thesis, we are collecting the exosomes from HeLa cervical cancer cells. Then we modified the exosomes with docetaxel load. Docetaxel is the taxane drug, this microtubule inhibitors. And we are comparing to the control cells. If you compare these cells, compare the cell, control cell is not effective for the exosome targeting therapy. But cancer cells, want to do combining cancer cells want to do interact with the another exosomes. They are both of the cell lines. We checked at the cell viability levels, and if you are using to the docetaxel 10 nanomolar, this is the more and decreasing the cell viability. Higher concentration is exodox. Exodox is the means docetaxel load of the exosomes. This reduced the number of the viable cells is 15%, and HeLa cells cell viability levels decreased to the 10 nanomolar concentration, and approximately 1 micrograms per milliliter. The exodox concentration is 50%. Viable cells is the number decreasing. This is the good result for us, and we control that how they affected the exosomes in apoptotic proteins and cell migration, in annexin 5 staining, how is the morphology, and we are comparing to that to the exosomes loaded, docetaxel loaded exosomes is more effective in HeLa cancer cells, normal exosomes, because exosomes is only exosomes is including to the many proteins. They can be higher the cell viability if comparing to the normal drug, normal control. They are produced to the cell viability, but if you are loading or if you are modification to with the drug, directly they can be therapeutics. In other studies, when we collecting to the cells, stem cells exosomes, we are collecting to the woman Wharton jelly from umbilical cord, and we isolated the stem cells. Then after the stem cell isolation, we characterized all of the cells, CD45, 44, CD105, CD90, CD34. We using the fluorescent microscope and flow cytometry, we isolated the pure mesenchymal stem cells. Then we start with these cells. If you are start with the cells is producing to the more exosomes, then we collected the exosomes. We checked the exosomes biomarkers, CD9, CD63, CD81, and we control that this one the electron microscopy size, and we loading to this carrier system paclitaxel. Paclitaxel is another microtubule inhibitors, and we control that how many how they are releasing the drugs. how many times they can be releasing the drugs. And we control the in HeLa cancer cells. And we use it the mouse fibroblast cells is control cells. In our studies, PAC IC50 values in exopac, paclitaxel load exo, and 12 nanomolar concentration in HeLa cells. This is the important for us. If you are using the normal paclitaxel, you can be used the 25 or 20 nanomolar, but we are including in the exosomes, we are using the lower concentration, the chemotherapies, and we control that is there a interacted to the EMT related proteins? How is the EMT transmission proteins is the interact? We found that yes, in exopac is the effective in EMT. Generally, EMT protein is the decreasing. They are giving to this result is show that, and this one metastatic or metastatic tumor cells can be useful to this therapy. And we check that EMT proteins and EMT genes with together, and Annexin 5 levels we check that. We compared that the control cells in exosomes, paclitaxel load exosomes is 33% is the cell viability. This is decreasing to the cell viability. Apoptotic proteins is and EMT proteins is interacted with them. In our studies, we use the platelet exosomes. Firstly, we healthy person, we isolated the platelets from blood. Then we control that the platelet is giving to the some stimulation. We ADP activation, we use it to the ATP activation. When we are treatment to the ADP 24 hours, platelet giving to the more, platelet secreting to the more exosomes. Then we connecting to these exosomes, CD9 and CD62. CD62 is the biomarker of the platelets, and CD9 is the biomarker for the exosomes. We compare that, and then we check that to the electron microscopy and zetasizer for nanometer of the Hounsfield scale. Then we load into this exosomes is doxorubicin. In doxorubicin releasing time, we control that, and we characterizing to the drug loaded exosomes and non-drug loaded exosomes. Then we use it to the MDA-MB cells. This one, MDA-MB cells is the triple negative breast cancer cells. You can now using to the for targeting therapy. This is important for us, and we check that the MCF cells is many surface marker, or this is the many people is studying for the drug targeting therapy in the MCF cells. MDA-MB triple negative cancer is the important for us. Then in MDA cells, we put in the we incubated the platelet exosomes or doxorubicin loaded platelet exosomes. We compared that with together. This is the effective platelet doxorubicin loaded platelet exosomes because platelets wants to do connecting with the cancer cells. This is the advantage for us. Exosomes want to do that. And we analyze it to the apoptotic analysis, and platelet exo and doxorubicin and platelet exo doxorubicin. And generally, if we are comparing to the control cells, doxorubicin is effective. We know that. But platelet exodoxo group is the migrated to the lower surface of the membrane compared to the cells in the control group. And the same to annexin 5 levels. Early and the late apoptosis is significantly increasing to the more intensely platelet exodoxorubicin groups. A morphological and apoptotic change in we examined that the acridine orange syndrome staining. Then green and red ratio is the decrease, this significantly increased in doxorubicin and platelet exodoxorubicin compared to control cells. You know that doxorubicin loaded exosomes, if you are producing platelets, this can be useful in MD-AMD therapy. And last paper from my PhD students, we did that raloxifene loaded and aptamer bounded exosomes. This we want to study in autophagy and apoptotic deaths. We are using this lysosomotropic effects. Some drug is lysosomotropic agents cross the lysosomal membrane. They became the protonated and they accumulated in the lysosomes, cytoplasm. When the concentration of the lysosomic agents reaches a critical level, the agent acquires the membranolytic characteristic, allowing the lysosomal contents to be released into the cell cytoplasm. The leakage of lysosomal acid hydrolysis trigger the cell death and mechanism in the cytoplasm. Therefore, it is essential for lysosomotropic drugs, including raloxifene. Raloxifene is the most popular lysosomotic activity, we know that, to be targeted to cells and formulation with delivery system in cancer therapy. For the targeted, we use the aptamer. Aptamer is the oligonucleotide part. And raloxifene, in this study, we focusing on raloxifene was formulated utilizing the exosomes, which part of the cells and function as nature carries. The autophagic effects were investigated by diving into the cervical cancer cells near aptamers. We isolating to the exosomes from HeLa cells. Then we modified the exosomes with surface of the binding to the aptamer. Then we loading in the raloxifene. Then we control that in raloxifene loading exosomes and normal exosomes. Raloxifene loading exosomes is a little bit more than aptamer binding, and raloxifene loading exosomes bigger than the normal exosomes. We check that the exosomes biomarkers and concentration, which aptamer is the more specific to this one. We check that we designed the 2 or 3 aptamers, and we selected that the 2 aptamers, and we control that the aptamer is binding in exosome surface, and raloxifene is releasing to the drugs the time dependent in different pH condition. Then we control that the uptake of the experiment of cytotoxic effects of exosomes, raloxifene and exo-aptamer raloxifene, always formulation. The changes in the cell morphology after the treatment of the raloxifene exo-aptamer raloxifene formulation in HeLa cells, we examined that with inverted microscope. It was determined that the cells in the exo-aptamer treated groups moved away from each other and their cell size decreased compared to the cells is the control group. IC50 really is low if compared to the normal raloxifene, and migration assay cells treated with the Relapse the migration rate decreasing to the more than 55% in 74 hours. We checked that the 0.72 hours in saturated with exo aptamer raloxifene formulation and migration rate decreasing to the more than 46% in 74 hours. In the control that how is the annexin staining and apoptotic proteins, especially mitochondrial apoptosis, is important for us. This study determined that the autophagic death mechanisms was triggered by increasing in the expression of the LC3AD and Becklin-1 autophagic proteins in HeLa cervical cancer cells treated with exoaptamer raloxifene formulation. We checked that apoptotic proteins and autophagic proteins and lysosomal drugs can be useful for loading in exosomes. And drug delivery can be many useful in this different cell type. We believe that in this situation, exosomes which have received a lot of attention in the field of the biomedicine in recent years. The unique advantage such as easy loading of multiple molecules, potential for targeting, potential for engineering, low immunogenicity, and suitable for repeated administration. As the research's hotspot, exosomes have become a potential effective method for disease diagnosis and treatment, and have bright prospects. Of course, exosomes have some limitation of their own. At the present stage, the research on exosome is not abundant, so the productivity is relatively low, which is also a direction that needs to be improved with this field. Although the use of the exosomes as a drug or gene delivery vehicles is still in its inefficiency. We believe that with the depending on exosome research and exosome therapy may eventually lead to major breakouts in the field of drug delivery in gynecological cancer. And personal medicine is the important this station. We are expecting that the exosomes can be approved with some cancer therapy. And I want to thanks to my team and my foundation. Finally, I would like to thank my work team and the institution that supports of funding agency us. Thank you so much, and this organization committee. Thank you.
Thank you for your presentation, Doctor. Now, if any participants have any questions, they can ask now. Okay, if there is no questions, now we will look forward. And now I'm inviting Dr. Dorothy, practice for hematology and oncology, Germany, to deliver her speech on individual treatment approach to primary NEBC, important aspects from extensive tumor profiling.
Hello, can you hear me?
Yes, doctor.
Yeah, can you hear us? Okay, can I start?
Yes, please, doctor, you can
Okay,
start
thank
now.
you. Yes. Dear colleagues, now I want to give you a presentation about an exotic cancer type, the neuroendocrine breast cancer and its diagnostic and therapeutic characteristics. It's a rare entity accounting for less than 0.1% of all breast carcinomas and 1% of all neuroendocrine tumors. Diagnosis of NEBC is often challenging as other neuroendocrine tumors, but also lung, gastrointestinal, and pancreatic cancers as primary extramammary tumors need to be excluded. Generally, morphology remains the base of pathologic classification, but NEBC do not exhibit a definite and unequivocally recognizable morphology. So diagnosis often relies on immunocytochemistry staining for chromogranin A and synaptophasing, which are sometimes also expressed in other non-neuroendocrine tumors. Adjunctive staining, for example, for mammaglobin, GATA3, and GCDFP15, allows to confirm memory origin. While above-mentioned immunocytochemistry staining is not conducted routinely, it's difficult to evaluate the real incidence of NEBC. Observation shows a neuroendocrine differentiation in up to 20% of all breast carcinomas. This is inconsistent to the fact that NEBC are diagnosed in less than 0.1% of all breast carcinomas, based on the latest WHA classification in 2019. Due to low prevalence of these tumors and successive changes in their diagnostic criteria over the years, no therapeutic guidelines have been established to date. In most cases, treatment strategies in NEBC are empirical, in absence of prospective trial data on NEBC cohorts. NEBCs are mostly associated with poor long-term survival and with rapid therapy resistance development. Surgical intervention is currently the mainstay of therapeutic approach. Systemic treatment strategies are generally chosen based on clinical pathological features like TNM status and aggressiveness of tumor, age, and comorbidity of patient. If curative chemotherapy is necessary, NEBC has been treated analog to adenocarcinomas of the breast or small cell lung cancer, representing neuroendocrine carcinomas. But what is tipping the scales? So for gastrointestinal neuroendocrine carcinomas, the proliferation index Ka67 has been used to predict clinical behavior. And a value greater than 15% is associated with early metastasis and with short overall survival. So due to lacking recommendations, it seems to be reasonable to use exactly this proliferation index as an indicator for choice of chemotherapy, as in other neuroendocrine carcinomas. The combination of surgery, radiotherapy, and chemotherapy showed promising results, but there are no guidelines for staging and therapy, nor in the early stages, neither in the metastatic setting. So it leaves the treating oncologist to opt for suitable systemic treatments. Nowadays, development of tumor profiling provides opportunity for individual precision therapies to evaluate, for example, targetable genetic alterations, respecting involved activation and inhibition of signal transduction pathways. And this tool is useful for rare tumors without existing therapy guidelines and for tumors refractory to prior therapy. It offers the possibility to match the right drug to the patient to improve patient's outcome. I want to illustrate the therapeutic challenges presenting the epicrisis of following two patients. First, there was a 67-year-old female diagnosed with NEBC of small cell subtype, undergoing surgery and considering definite tumor stage. There was an indication for adjuvant chemotherapy. And CTX was tailored to high proliferation index of 60%. followed. And so she received 6 cycles of carboplatin etoposide, followed by radiotherapy of the breast, but not of the brain. After 16 months, after completing adjuvant treatment, a solitary brain metastasis was diagnosed and extirpated. Considering micrometastasis of the brain, topotecan was administered due to its ability to cross the blood-brain barrier. But therapy failed. A little bit later, lung and pleural metastases were seen. And it was an aggressive scenario, high-grade, highly proliferating tumor. And at this moment, no appropriate clinical trials were available. And we wanted to change treatment strategy, more focusing on neuroendocrine characteristics. So we proposed dotatate-based PET-CT was possibly following peptide receptor radionuclide therapy as an experimental diagnostic and therapeutic alternative. Somatostatin receptor expression is mainly considered a feature of well-differentiated gastrointestinal neuroendocrine tumor. But this aggressive scenario raises the provocative question of indication for dotatate-based PET-CT. Waiternebe and colleagues found positive correlation between SSTR expression in the midgut and hindgut to grading and proliferation index. In NABC, the correlation is unknown. One case reported by Savelli and colleagues showed promising efficacy of radioligand therapy in neuroendocrine breast cancers. However, this proposal was rejected by the patient herself, and an individual approach was necessary. So tumor profiling was performed by Exacta using peripheral blood cells to detect targetable genetic alterations by NGS, gene expression profiles, further targets determined by immunocytochemistry staining, pharmacogenetics of tumor-specific medication, and chemosensitivity sensitivity testing using circulating tumor cells. So NGS revealed an activating mutation of the PA3K, which is part of the PA3K mTOR pathway. It's important for proliferation, migration, cell survival, tumor metabolism. It's observed quite frequent in neuroendocrine tumors, but information about incidence and clinical impact in NABC is inconsistent. This alteration suggests therapeutic benefit from mTOR or PA3K inhibition across different cancer types. Due to extended metastasis and high proliferation index, gemcitabine and oxaliplatin based on chemosensitivity testing were applied together with mTOR inhibitor temsirolimus. This therapy was tailored to individual tumor characteristics, but no response was seen despite molecular evidence and CTX testing. Why did this precise therapy fail? NGS revealed PA3K mutation as the only targetable alteration, and further information about this important pathway would be necessary. Are there any predictive factors? First, there's the just mentioned mutation, like in this case. Further, possible predictive factors concerning inhibition of PA3K pathway like PTEN loss, KRAS, P53 mutations, FGFR1/2 amplification. In fact, they are under exploration. In case of our patient, molecular tumor profiling did not reveal any of the above-mentioned alterations. But gene alterations do not always implicate adequate gene expression. So the next step towards this evaluation was to consider special messenger RNA levels. So we had a look to peripheral effector mechanism. This simplified graph illustrated the branches of PA3K pathway, and the upper sheet reflects the peripheral parameters of mTOR pathway, which were downregulated. For example, RAP as a direct activator of mTOR, or even more peripheral, ribosomal protein 6, which is mainly affected by temsirolimus, or eukaryotic initiation factor 4B. So in retrospect, what did we do? It could be hypothesized that we inhibited a just down-regulated pathway. It appeared that the proliferation-promoting influence was not mainly triggered by mTOR, focusing only on molecular base. This was not predictable. We wanted to focus therapy on the only targetable alteration. So we had a look to the other branches of PI3K pathway. Alpelisib, as a direct inhibitor of PI3K, would not suffice to block the whole pathway to a large extent. And this assumption could be supported by the fact that important factors of tumor metabolism, cell cycle progression, and cell survival weren't upregulated on messenger RNA base. To address this issue that many decisive components of PI3K pathway weren't upregulated, in taking into account a high proliferation rate, a cytotoxic agent based on carboplatin was administered, analog to this study, in combination with alpelisib. For the first time, a remarkable therapeutic effect was seen. Oxygenation improved significantly, and patients changed from ECOG 2 to ECOG 0 within 3 weeks. Imaging showed normal pleural effusion, and it looked like a first wave in the right direction. But 7 weeks later, she suffered from an etiologically unclear thoracic pain with sudden death. We wanted to arrange for an autopsy, but it wasn't possible. The second patient was a 51-year-old female diagnosed with NEBC of large cell subtypes, undergoing surgery and considering definite tumor stage. There was also an indication for adjuvant chemotherapy. CTX was focused, tailored on high proliferation index of 40%, so she received 6 cycles of carboplatin etoposide, followed by radiotherapy of the breast. After completing adjuvant therapy with poor clinical tolerability, only 1 month later, liver metastases were detected, and a planned atypical liver resection was rejected due to intraoperatively diagnosed diffuse spread also into the left lobe. From liver biopsy resulted a highly proliferating metastasis, poorly differentiated, deriving from known NEBC. So it was a threatening situation, and tumor profiling using exacta analysis, this time based on liver tissue and blood, was performed to adapt tumor-specific therapy exactly to tumor's characteristics. Waiting for results for 2 weeks, diffuse bone metastasis and infiltration of spinal canal developed, and radiotherapy was applied. Following alterations with certain clinical impact resulted from tumor profiling. The first alteration was the STK11 mutation, which are reported in NEC such as large cell subtypes, but which are rare in breast cancer. Exactly this mutation is characterized as a loss of function mutation, which can lead to activation of mTOR. It's associated with lack of PD-L1 expression. In fact, here was no PD-L1 expression diagnosed by immunocytochemistry staining, MSI stable and low tumor burden. So it was not suggestive for benefit from checkpoint inhibitors. Another mutation, the TP53 PR290 frameshift, is characterized as a function is associated with functional loss of p53 activity, which can additionally contribute to activation of PI3K mTOR pathway. Furthermore, there's mounting clinical evidence that emphasizes the importance of TP53 mutations in predicting response to anti-androgenetic therapy. Preclinical and clinical data demonstrate that loss of function mutations of TP53 induce higher levels of vascular endothelial growth factor A, hypoxia-induced factor alpha, as it is revealed exactly in this patient. Messenger RNA-based pathway modeling shows increased signaling of androgenetic pathways. With positive immunocytochemistry staining for vascular endothelial growth factor A. Beyond these alterations, NGS revealed an amplification of FGFR1 and 2, which might hyperactivate PH3K-mTOR pathway and partially MAP kinase pathway. Especially FGFR1 amplification is associated with resistance to endocrine therapy and PH3K inhibitors, while retaining efficacy to mTOR inhibition. In the synopsis of all molecular genetic findings, it seems to be promising to applicate an mTOR inhibitor. But due to a prior experience with tumor profiling, we further evaluated the mTOR effect on protein synthesis. And we had a look at peripheral effectors at messenger RNA level. So ribosomal protein 6 kinase 1 and 2 were overexpressed, which stimulate protein synthesis by eukaryotic initiation factor 4B and ribosomal protein 6. But mTOR inhibition as monotherapy, I want to give you some reflections about this issue. Everolimus, as an allosteric inhibitor of mTOR-C1, seems to affect mainly mTOR-C1 substrates, such as ribosomal protein 6, rather than stronger factors like eukaryotic initiation factor 4B. Consequently, mTOR-C1-mediated protein synthesis could only incompletely be inhibited. It can lead to potential suppression of negative feedback loops, for example, increased IROS1, which activates PH3K-AKT pathway. And downregulation of ribosomal protein 6, for example, by everolimus, can in turn lead to AKT activation. And interconnected pathways like MAP kinase pathway may be stimulated. So inhibition of one protein of mTOR could provoke stimulation at another level. But an advantage of mTOR inhibition in combination with anti-angiogenetic therapy could be assumed because angiogenetic pathways were upregulated. So bevacizumab was added to everolimus. Due to highly proliferating disease with extant metastasis, the cytotoxic substance was administered according to chemosensitivity testing. And this combination was well tolerated. She expressed high quality of life with stable disease for 3 months. But 3 months later, tumor progressed dramatically, and patient died due to liver insufficiency. Behavior of tumors is characterized by myriad of mechanisms, and each factor influences processes of survival and proliferation singularly and cumulatively. This complex context illustrates the advantage of evaluation of tumor-specific targetable characteristics based on above-mentioned components. This comprehensive tool was used in 2 patients suffering from a highly aggressive cancer type after failing of empirical therapies, in analogy to recommendations for breast cancer and neuroendocrine carcinomas. Especially in rare cancers with bad prognosis just from the beginning, we should consider tailored therapy earlier to prove that extensive diagnostic and therapeutic approach could provide a benefit. Currently, tumor profiling delivers advantages only to a minority of patients. But your trials showed beneficial outcomes even in late-stage patients, with several previous therapies applying enhanced molecular analysis comprising also cytological features and other cancer characteristics. More data are existing which demonstrate that matched patients versus unmatched patients had higher rates of long stable disease and longer PFS. Higher matching score is correlated with longer PFS, as it is demonstrated in the Winter trial. Combining genomic and transcriptional profiling is useful to improve personalized treatment recommendation and subsequently patient outcome. If possible, not only targets may be considered for choice of therapy, but also the context of whole pathway network together with biomarkers. Bridging to a further outlook, we have to extend the diagnostic tool to the metabolome Knapstead and colleagues could show in vitro that cells resistant to PI3K-mTOR inhibition differ with regards to metabolic profile compared to sensitive cells. But no single metabolite identified responders from non-responders. So this possible importance of various metabolites should be considered if future clinical studies, for example, based on mTOR inhibition and combined therapy, are planned and analyzed. This is only one example for new fields of interest to develop novel therapeutic strategies. And I want to conclude my presentation with Goethe. Every solution to a problem is a new problem, but I want to add which is being solved again. Thank you for your attention.
Hello, doctor. Thank you for your presentation. I hope all of the participants have gained critical insights from that. And if any of the participants have any questions, they can go on and ask. Doctor, we have a question for you.
Yes.
The chat box.
Yes.
There is a question from Dr. Lee. He's asking, thank you for your presentation. What do you recommend for ER plus low stage NEBC?
Yes, it's endocrine therapy is recommended concerning empirical experience, but you have to exclude an FGFR1 amplification. And in this case, the patient would, it would be suggested for benefit from endocrine treatment.
Thank you, doctor. I hope Dr. Lee's doubts have been cleared. If anyone have any further questions, they can go on and ask. There is again a question from Dr. Lee. Would you recommend NGS for all NEBC patients then?
Yes, concerning my the little experience, I would recommend it because only after the results of extended tumor profiling, and I want extend tumor profiling to gene expression profiles. So the greatest benefit was tailoring a therapy to exactly to the results of extended tumor profiling. Yes, if it is possible, because NGS or tumor profiling is always available for a minority of patients. Yes, because the experience based on treatment strategies analog to breast cancer or neuroendocrine carcinomas are only characterized by limited success and benefit.
Thank you once again, doctor. I hope Dr. Lee's doubts have been cleared. And it's, yeah, there's one more query. I would read it out for you. What is there if FGFR abnormality in a tumor? If not endocrine therapy, what would you use to treat it?
In case of endocrine or hormonal expression, or can you clarify the question? if a tumor expressed or showed an FGFR1 amplification. So it implicated a stimulation of endocrine activity and, for example, AKT, so which in turn stimulates mTOR. And in this case, it's a little bit depending on the concrete situation, you have to block, you have to applicate mTOR, for example, to prevent proliferation by stimulating mTOR by FGFR1 amplification. So it's a little bit depending. You have to take a decision basing on the synopsis of all parameters. But I try to explain the importance of an FGFR1 amplification. It can provoke stimulating mTOR pathway by activating of AKT.
Thank you very much, Doctor, for clearing all our queries. I hope all of our participants' doubts have been cleared. Any further questions are most welcome. Okay, in case there are no questions, and if there are also, we can discuss it at the end of the session. Thank you once again, Doctor, for your presentation and your lively discussion that we had. Thank you so much. Now I would like to move on to our next speaker. I would like to call upon Dr. Shinichi Hori from Institute for Image Guided Therapy, Japan, to deliver his speech on transarterial approach to the primary breast cancer and axillary lymph node metastasis. Hello, doctor. Can you hear me? Dr. Shinichi?
Yes, I'm here. I can hear you.
Yeah, hi. You can start your presentation, doctor.
Yes. I've already sent my presentation. Can you start my presentation?
Sure. Do you want me to play it? Play the video?
Yes. Yes.
Okay, sure.
Yes.
Just give me a second. Yeah. Can you guys hear the audio? Is the audio hello?
Hello.
Is the video audible to all of you?
Yes, yes.
Okay,
I can
okay.
see the video.
Thank you. Okay, I'll just start.
All right. We are doing the transarterial approach to the primary breast cancer. And here's the disclosure. Can you start my video presentation?
What? Any closer?
Hello.
Hello.
Okay, do you want me to play the presentation?
No. I have already sent the video presentation. Can you start my video presentation?
Yeah, this is a video presentation, doctor. That's why I asked if the sound is audible to all of you or not. This is only the video presentation that you have sent us.
So you mean that I have to present my presentation now?
Okay, so you want me to show the slides, your PowerPoint presentation, right?
Yeah, it's okay. Okay. I'll start the presentation. Okay. We are doing.
Doctor, I'm sorry, I didn't get you. Can you please let me know? Do you want me to play the video presentation or the PowerPoint presentation? In video, we have pre-recorded audio of yours.
Yeah, yeah.
Do you want me to play that?
I prefer the coded video.
Video. Okay, okay, okay. Just give me a
Okay.
second. I'll play it.
Okay. I'm sorry.
Sorry. Yeah, I'm so sorry for delaying.
Okay, please start.
Hello, doctor. Video quality is the sound in the video is very low. Not able to all of everyone will see it. Where I am
Excuse me. Excuse me, there is a big problem in video.
Yeah, doctor.
We have there is a big problem in video. Can I do the same presentation from now using my?
Yeah, no problem. I think there is some problem with the system, or maybe because of the video. I don't know. But yes, you can sure you can do the live presentation now. I'll stop sharing the screen, and if you want me,
Okay.
I'll share the presentation. Or do you want me to share? Tell me.
Okay. So. Wait a moment, please.
Yeah, sure, doctor. Take your time.
Can you see my video? Excuse me. Can you see my video? I'm sorry, a presentation?
No, doctor, the presentation is not visible.
How is this? Can you see that?
No, doctor. Please first go to the Zoom meeting, and then there you can see the option share screen. After that, on your computer screen, you can on your presentation. Then we will be able to see that. We can see it, doctor. We can see your
Okay.
presentation. Yeah.
So now I can really start my presentation. Okay, my talk is about trans-arterial approach to the primary breast cancer and lymph node metastasis. And this is a very challenging field of the interventional radiology. There is no disclosure. And I am from the Institute for Image Guided Therapy that locates just in front of the Osaka International Airport. And this is one of the biggest center for interventional oncology in Japan. We are doing a lot of treatment, transarterial treatment, not only for the hepatocellular carcinoma, but also lung cancer and breast cancer and so on. Here is the clinical background of the breast cancer. It is most common cancer for women, and there is a limited treatment options for locally advanced breast cancer. And usually the patient are in serious conditions, and prognosis is always very poor. And here is the patient who has the big tumor in the chest wall, and she was infected, and it smells bad, and she had a pain. And the other patient had the active bleeding from the extruding tumors. That the very, very big problem. And this is rationale for transarterial treatment. Usually, the breast cancer is hypervascular tumor, and it is possible to access to the tumor using the microcatheter. And usually, breast cancer is sensitive to anti-neoplastic agent, and skin necrosis is a big problem, but there is no damage for the skin as long as we use the spherical embolic material. And usually, breast cancer is very, very hypervascular. It means a vascular leak. And other patient has the enlarged arteries. The diagnostic imaging is very, very important. Nowadays, we can use a very, very excellent CT scan, and we can get not only the actual images, but also the very, very beautiful 3D images of the vascular structures. And during the treatment, we are using the angio CT scan, which means that the angio suits with the CT scan in the same room, and using these machines, we can get the intra-arterial 3D images, and they are very, very useful to recognize the feeding artery to the tumors. Another important point is the embolic material, and safe and effective embolic material is necessary. We are using the super absorbent polymer microsphere. The commercial name is the HepaSphere. And this is the microsphere, and when we inject into the cell line, it starts to expand within 10 seconds, and after 1 minute, we can see the double-sized microspheres absorbing the saline or blood serum. And I want to show you the treatment method. Here is a patient who had the huge tumors in the primary breast, and she has also axillary lymph node metastasis, and both tumors are visualized by the 3D images. With the guidance of these images, we can insert a catheter to the internal mammalian artery or very tiny artery from the brachial arteries. And during the angiography, we try to do the CT scan, and then we can understand the blood supply from each artery. Here is the internal thoracic artery, and here is the another arterial circulation to the tumor. And at the first things we have to do is the drug infusion from each artery. And after the infusion, we do the embolization using the microspheres. And the end point of the embolization is not the tight occlusion. The end point is slowdown of the blood flow. And we have to preserve the feeding artery because we have to repeat the treatment. After the treatment, we always follow up the patient using the CT scan to evaluate the effectiveness and evaluate the clinical symptoms. And we investigated local recurrent tumors after standard therapies. Number of the patient was 38. Target lesion was breast recurrent tumor and axillary lymph node metastasis. This was the 5 years experience, and this was the retrospective study. And this is the result. The number of the treatment session was almost 6 sessions, and the number of the arteries we treated is around 5. And anti-cancer drugs we used the doxorubicin, epirubicin, and cisplatin, and docetaxel, fluorouracil, and bevacizumab. All of these anti-cancer drugs are approved for the breast cancer treatment. The total dose was always lower than the systemic doses. So we are using the 20 or 30% of the systemic chemotherapy doses. Hemosphere, that was the superabsorbent polymer, did not cause any skin damage. Systemic adverse events were negligible, and the local adverse event were redness of the skin for several days and pigmentation for several months by anthracycline, but that was not a big problem. I want to show us some clinical cases. Here is the patient with the local recurrent chest wall recurrence after the standard therapy. She had many lesions around in the chest wall. And when she consulted us, she had the active bleeding from the tumors. It was very difficult to control the bleeding by pressing the bleeding point. Then we brought her to the angio suits, and we did the angiography, and we found the enlarged artery coming to the tumors, and we did the embolization therapy from this point, and we have to insert the catheter to the lateral thoracic artery, and we did the embolization as well. And this is the result. After 2 months, we found the shrinkage of the tumors, but we saw that we continued the treatment. And this is the 6 months after the treatment, we could find the shrinkage of the tumor, and there was no risks for the bleeding. I want to show you the other cases. Here is a patient with a T4 tumors, and this is the result after 1 month, and we confirm the shrinkage of the tumor, not only the primary but also the actual lesion. Then we did continue the treatment, and this is the 1 year after the treatment. We found the complete remission of the tumor in the breast, and we can see the enlargement of the actual lymph node metastasis. Here is another patient. She also had the T4 tumors, and we did the treatment, and we found the shrinkage of the tumor in the primary region, and we continue the treatment, and this is a result 1 year after the treatment, and we found this shrinkage, not only the primary but also the axillary lesions. I want to show you another patient. She had the primary tumor after the primary tumor recurrence after the standard therapy, and she also had the lymph node metastasis. And we infused 30 milligrams of cisplatin and 20 milligrams of docetaxel and 5-FU. Embolization was done by the docetaxel loaded microsphere, and this is the result in a month. And then we did the second treatment, and this is the result after the second treatment, and this is the result after the 3 sessions of the treatment. We found the shrinkage, and we sent her back to the breast surgeon, and the radical mastectomy was done. Residual breast cancer tissue was found in a small area just beneath the skin. Okay, how about the lymph node metastasis? We insert a catheter, and this is the result in a month, and this is the result after second session, and this is the after the third session. Lymph adenectomy was also done, and the histopathological specimen showed that complete necrosis of the lymph node metastasis. I want to show you the very interesting case. Here is the patient after the mastectomy and the cystic chemotherapy. 5 years after the initial treatment, she had the chest wall tumor, and it was very painful, and fine needle biopsy showed metastatic breast cancer. We did the treatment, and this is the result after 2 months, and we found the shrinkage. And this is the follow-up study at 4 years. In the case of the breast cancer, we have to continue the follow-up study to check the recurrence for long years. And this is the result after 11 years. She got the second recurrence in the same place. So we have to do something for her, and we did the same treatment, and you can see a very hypervascular tumor in the chest wall, and we did the treatment using the microcatheter, and we confirmed the retention of the anti-cancer drugs in the target tumors. We also insert a catheter to the acromiothoracic artery to check the blood supply to the tumor, and we found the small part of the tumor was enhanced from this artery. So we did the treatment in this artery as well. And this is the result after 1 month after the second treatment, and this is the result after 12 years. Totally, she had survived for 17 years after the recurrent tumor treatment. Here is another miserable patient. She had the standard therapy, but the result was like that. She had the infection and she had the recurrent tumors and she had the pain in the chest wall. And none of the treatment can be done in these patients. We use the usual anti-cancer drugs, and we did the embolization using the microspheres. And this is the result after 1 month, and we found the uh, reduction of the tumors, and bleeding has gone, and it looks very good. And then we continue the treatment, and this is a result after 26 months after the treatment. So she was very happy, and she can do anything she wants in daily life. Here is the survival curves of the 38 patients. It was very difficult to compare to the compare with another treatment, but overall survival was 38 months, and it was successful. But in the case of the lung metastasis, the prognosis is a little bit worse. And I'm sorry, here is the liver metastasis. If the patient had the liver metastasis in the treatment, the prognosis was very poor. It was same as a bone metastasis. I want to introduce the transarterial treatment for the de novo breast cancer. Recently, we have a lot of experience to treat the previously untreated breast cancer. Here, the patient, she had a huge tumor, and she had the active bleeding from the tumor, and she had the skin metastasis. And CT scan showed the big tumor in the breast region, and it was a big problem. And we took the 3D vascular images, and it helped us to insert a catheter safely to the target lesion. And here is the CT scan and DSA study during the treatment. And you can see the good enhancement of the tumors. And when you insert a catheter into the internal mammalian artery, you can see the good enhancement in the medial part of the tumor. And this is the result. After 8 months, we succeeded to reduce the tumor burden, but the problem is the rest of the tumor in the chest wall. So we have to do some additional treatment. In this case, we did the local immunotherapy and this is the result after 14 months. So it is possible to make the tumor smaller and smaller using the technique, transarterial treatment technique. Here is another patient who has the huge tumor in the chest wall. She had the active bleeding from the tumors, and she had very many kind of the difficulties to live. And this is the CT scan and vascular reconstruction images. In the as to the primary tumors, we did the treatment, and we not only the primary but also the lymph node metastasis, and it sometimes it is very difficult to insert a catheter to the lymph node metastasis, but theoretically, it is possible to insert a catheter in all cases. And this is the result. After 3 months, we found the disappearance of extruding tumors, and lymph node metastases are smaller than before. So the patient condition became better, and the she have to continue the treatment to get the complete remission of the tumor. And this is the 1 month after the treatment, we found the disappearance of extruding tumors, but in the margin of the tumor, we found the rest of the tumor, so we have to continue the treatment, and this is the result after 2 months. But actually speaking, we have to continue the treatment, not only the transarterial treatment, but also the radiotherapy or systemic chemotherapy and immunotherapy. And this is the result. Survival curves of the 24 cases of the de novo breast cancer. Survival was 34 months, and we were convinced that we could extend the patient prognosis. Here is the conclusion. Technical aspect. Transarterial approach is feasible. 3D images, a microcatheter, and spherical embolic material are essential. Angio-CT or cone beam CT is helpful to identify the blood supply to the tumor. TACE is effective to control the breast tumor and accelerate lymph node metastasis. Systemic side effects are quite limited, and skin pigmentation after several months sometimes occurs. Transarterial treatment can offer better quality of life with less adverse events. Transarterial treatment has a survival merit. Thank you for your attention. Thank you very much.
Thank you, doctor, for your presentations. And if any of the participants have any questions, they can feel free to ask. In case there are no further questions, we would like to move to our next presentation. Thank you once again, Dr. Shinichi, for your presentation and your
Thank you very much.
Yeah, thank you. Now I would like to call upon our next speaker, Dr. Swapna Ravi from Gunderson Health System USA, to deliver her talk on role of hallmarks in breast cancer. Hello, Dr. Swapna, are you there? Can you listen me? Can you hear me?
Yeah, I'm here.
Yeah, most welcome. You can start your presentation now.
Yes. Are you able to see my screen?
Yes, we can see your screen. Please make it full screen. Yeah, we can see it now. Thank you.
All right. Good morning, everyone. I'm Swapna Ravi, and I'm from Gunderson Health System. Today, I would like to speak about the role of hallmarks in breast cancer. A normal cell acquires several capabilities to transform itself into a cancer cell and eventually grow and spread. And these capabilities are defined as hallmarks by Hanahan et al. In 2000. And since then, a remarkable progress has been made in this field of science. In our recent review paper titled An Update to Hallmarks of Cancer, we reviewed these updates within the last couple of decades and described pro-survival autophagy as a new hallmark of cancer. As you see in the picture here, a normal cell is being or utilizing several of these capabilities or hallmarks and the enabling characteristics and transforming itself into the tumor cell. Looking closely at the picture here, these hallmarks are basically enabling this cell to sustain proliferative signaling, at the same time avoiding growth suppressors, immune suppressors, and cell death, and also enabling replicative immortality. Since a cancer cell has the ability to proliferate and grow over the normal cells, it has to avoid the growth suppressors and the mechanisms of cell death. And in order to survive in the nutrient stress or the metabolic stress state, the cancer cell has several mechanisms such as reprogramming energy metabolism and angiogenesis. Angiogenesis is specifically utilized by a cancer cell in the response to hypoxia. Since this cancer cell is proliferating at such a high rate, there is always inadequate blood supply to the area of cancer, and with inducing angiogenesis or forming new blood vessels, it's increasing its own oxygen supply and surviving over the normal cells. And pro-survival autophagy, as I said, we describe this as a new hallmark, and this has been gaining more interest in the last decade. Basically, pro-survival autophagy enables the normal cell, when it's transformed into a tumor cell, utilize the damaged DNA and utilize the nutrients from it or the mitochondria from it. And eventually, in the presence of these hallmarks, the cancer cell is going to invade and metastasize. There are a couple of hallmarks that are described more as enabling characteristics. And if we see here, tumor promoting micro and macro environment is one of the enabling characteristics. In the last decade, especially, there has been more light on the tumor macro environment or the entire human system supporting the growth of the tumor cell. Epigenetic landscape, genome instability, and mutation basically helps the cell to acquire these hallmarks and also grow and spread. So as we see here, with all the proper hallmarks and the enabling characteristics, this cell is being transformed into the tumor cell and eventually seed and spread. These hallmarks are known to play a key role in the pathogenesis, treatment, and prognosis of breast cancer. Coming to the first core hallmark, sustaining proliferative signaling, we know several receptor tyrosine kinases like epidermal growth factor receptor, estrogen receptor, progesterone receptor, human epidermal growth factor 2 receptor, androgen receptor, and insulin-like growth factor 1 receptor, which play a key role in breast cancer proliferative signaling. And these are currently being targeted for treatment in breast cancer. And as a hallmark evading growth suppressors, we know a couple of genes such as PRB and P53, which play a key role in growth suppression. Mutation in these tumor suppressor genes, especially TP53, is one of the prognostic markers used to determine response to the treatment in breast cancer. Resisting cell death. A tumor cell, in order to survive, has to come across or avoid apoptosis which is one of the defense mechanisms from the body. And BCL2 is an anti-apoptotic gene and is a prognostic marker in breast cancer. It is well known to be overexpressed in estrogen receptor positive cancer. A selective BCL2 inhibitor, venetoclax, is now being studied in a breast cancer clinical trial. Enabling replicative immortality. The tumors, as they proliferate, acquire telomerase function to form tumor-promoting mutations and at the same time avoiding cell senescence. A normal cell is supposed to die after a certain number of replications. In order to avoid that, the tumors have this telomerase function, and most breast cancers are known to have telomerase activity. Telomerase inhibition is being studied in combination with doxorubicin in breast cancer trials. Inducing angiogenesis, tumors produce several angiogenetic factors that favor the formation of new blood vessels in response to hypoxia. And again, this is because of the inadequate blood supply given the hypermetabolic or proliferative rate of the cancer cell. A monoclonal antibody, bevacizumab, is being used against vascular endothelial growth factor in breast cancer. Activating invasion and metastasis. This is such a devastating part of the cancer. Metastasis is the cause of most cancer deaths. It is the leading cause of breast cancer deaths. Plasticity is being more highlighted in the recent hallmarks research as a core hallmark, and it's known to facilitate metastasis. Together, plasticity and metastasis are the biggest challenges we are facing today in cancer therapy. Reprogramming cellular metabolism. So as the tumors grow, they come across a nutrient-starving state. And metabolic reprogramming is a hallmark that's utilized by the tumor cells to survive in such states. This also is known to favor anti-tumor immunity or suppress anti-tumor immunity. And several metabolic agents such as arginine inhibitor are currently in clinical trials in combination with immunotherapy. This is one of the theoretical approach to overcome the immunotherapy resistance. And evading immune suppression. In order to survive and grow, the tumor cells have to avoid immune suppression. And immunotherapy is now very widely used against multiple cancers. Programmed cell death 1 or PD-1 inhibitor like pembrolizumab and programmed death ligand 1 inhibitor atezolizumab are used against breast cancer more commonly in immunotherapy. Unlocking phenotypic plasticity is described as a new core hallmark recently this year by Hanahan et al. In his updates. Phenotypic plasticity via epithelial to mesenchymal transition is favored through several signaling pathways, for example, MAP kinase and PI3 kinase. Increased plasticity enables not only the metastasis, but also treatment resistance in breast cancer. Determining the phenotypic presentation of the cancers, plasticity plays a significant role in treatment resistance. Targeting plasticity might be an option to suppress metastasis, but again, this is such a big challenge, given that the tumors can change into several phenotypes and come across treatment resistance. Pro-survival autophagy is described as a new core hallmark by us in our recent review paper. In the last decade, there's a tremendous progress in research on pro-survival autophagy, and more is being discovered on autophagy. During metabolic stress, autophagy helps cancer cells by recycling damaged intracellular material to functioning mitochondria. Autophagy markers like ATG5 were increased in breast cancer cells overexpressing KRAS. And autophagy is a potential anti-cancer therapeutic target, and several studies are ongoing to target autophagy. Cancer epigenetics, genome instability, and mutation is one of the enabling characteristics. Gene mutations instability basically help the cancer cells or the cells acquire these hallmarks in order to transform into tumor cell. We know very well breast cancer susceptibility genes 1 and 2, or in other words, BRCA1 and 2, are the most common breast cancer associated mutations. In addition to the mutation and genome instability, there are several non-mutational epigenetic mechanisms like DNA methylation that play a key role in determining cancer phenotypes. And this is one of the explanations for varied presentation of several cancers despite having the same mutation. Genetic and epigenetic mechanisms together facilitate the cancer development and progression. Tumor-promoting microenvironment is, again, an enabling characteristics. In order for the tumor to grow and spread eventually, there's a lot of support required from its microenvironment. Tumor exosomes in the microenvironment help a cancer cell to communicate with its macroenvironment, and eventually this bidirectional interaction is creating a niche favoring cancer metastasis, for example, the breast to brain metastasis. And depending on the interaction between each and every cancer cell and the macroenvironment, that's what decides the common metastatic areas for each cancer. Some stromal cells in the tumor microenvironment can undergo senescence during therapy and eventually wake up and facilitate tumor invasion and metastasis. Tumor promotion by inflammation is one of the roles played by the microenvironment. Tumor-promoting inflammation promotes cancer development, growth, and spread. Breast cancer cells overexpressing inflammatory cytokines like IL-1 beta can be targeted for therapy. Tumor macroenvironment. This is one of the areas gaining more interest, especially in the last few years. Tumor microenvironment includes several human systems like metabolic system, endocrine, lymphatic, hematopoietic, immunologic, microbiotic, and neurologic environments or systems. Tumor macroenvironment along with tumor microenvironment is key for any cell that's transformed into tumor cell to progress and metastasize. Even with the same gene mutations, there are several cases we see which do well without any progression or metastasis in several cancers. And that's the role of the tumor micro and macro environment, deciding the future of a cell that's had the proper mutation, but without a proper environment can grow or spread. Looking closely at the tumor macroenvironment, we know a couple of major metabolic disorders, diabetes and obesity, which are being studied or known to play a role in cancer development. Tumor growth is influenced by hormonal changes like estrogen or progesterone in breast cancer or testosterone in prostate cancer. And tumor growth is also influenced by the gut microbiota, which are known to play a role in tumor promoting inflammation. Tumor promoting neurogenesis is another tumor growth influencing factor. The neurons in the macroenvironment are known to promote the tumors. Glutamate released from local neurites is known to promote brain metastasis in breast cancer. Tumors communicate with systemic circulation via the lymphatic system, hematopoietic and immunologic systems by interacting with the bone marrow, help in suppressing anti-tumor immunity. Understanding these hallmarks of cancer is key for developing efficient diagnostic, therapeutic, and prognostic strategies in the cancer. Much more is yet to be discovered in this field, and I'm sure in the next decade, things will progress tremendously in improving cancer therapy. So in summary, I would like to highlight the core hallmarks here. Sustaining proliferative signaling, estrogen receptor being targeted in breast cancer is an example for that. Evading growth suppressors, and among the growth suppressors, TP53 as a prognostic marker in breast cancer. Resisting cell death and anti-apoptotic gene BCL2 is a prognostic marker again. Enabling replicative immortality, telomerase inhibition is being studied in combination with doxorubicin in breast cancer, and this is one of the examples on how understanding core hallmarks can help in the treatment of cancer. Inducing angiogenesis, bevacizumab, a monoclonal antibody being used in breast cancer, which targets this hallmark. Activating invasion and metastasis. This, along with plasticity, like I said, are the biggest challenges. Metastasis is the leading cause of breast cancer deaths. Reprogramming cellular metabolism. Metabolic agents like arginine inhibitor, there's several studies on glutamate. These are being studied in combination with immunotherapy in clinical trials. Evading immune suppression, pembrolizumab, atolizumab, and several programmed DET1 inhibitors or programmed DET ligand 1 inhibitors are used against multiple cancers and especially breast cancer. So the two new hallmarks, unlocking phenotypic plasticity and pro-survival autophagy. Much more is to be studied, especially with the phenotypic plasticity. And increased plasticity is known to facilitate metastasis and treatment resistance. So if we could understand this hallmark better and target it, it will be a new era of treatment in cancer. Pro-survival autophagy, since autophagy is being utilized by cancer to survive, this is a potential anti-cancer therapeutic target. Enabling characteristics which enable cancer initiation, progression, and metastasis are cancer epigenetics, genome instability and mutation, tumor micro and macro environment. And I'd like to thank you all for having me here with you. And I thank very much my team who helped me in this presentation. Thank you.
Thank you for your presentation, Dr. Swapna. If any participant have any questions, they can ask now. Okay, I think there is no questions. So now we have a short break of 10 minutes. So I request all the participants don't leave the meeting room.
Time yok.
Hello, everyone. Welcome back once again. Now we would like to continue our speaker circle. I'd like to invite Dr. Marwan Ubaid from King Hussein's Cancer Center, Jordan, to deliver his speech on does anesthesia affect cancer recurrence. Hello, doctor.
Hello,
As-
hi. Good
Yeah.
afternoon.
You have a very good afternoon to you.
My talk today about does anesthesia affect cancer recurrence? Is everything clear? My voice, the video, everything fine?
Yes, doctor.
Okay. So to start with, it's a topic that there are many issues about it. So it's not all related to anesthesia per se, but it is also about things related to perioperative period and whether anesthesia and its management, its manipulation can affect cancer recurrence or not. My name is Marwan Ubaid. I am consultant anesthetist at King Hussein Cancer Center in Amman, Jordan. My talk today will be about why this topic and its importance, some general things about cancer and its prevention, some basics, physiology, stress response, and why I am talking about these things, because they are all related to cancer and the recurrence as well. And also some of the causes and mechanisms of cancer. The potential effects of anesthesia on cancer recurrence, some studies, and also summary of my talk. Now, it's important to understand or to make people aware, especially doctors, that there are some effects of anesthetic medications on cancer recurrence. We know that cancer is one of the leading causes of death worldwide, and according to the WHO, it's about 10 million deaths in 2020, or nearly 1 in 6 deaths is related to cancer. In the UK, 1 in 2 in the UK people will develop cancer in their lifetime. You know, as we get older, the chances of getting cancer is more. So there is chance that 1 in 2 people will get cancer during their lifetime. Most common causes of cancer, or most common types of cancer, is breast cancer is first, followed by lung cancer, prostate cancer, and bowel cancer. These 4 cancers are the most common causes. However, the most common causes of death, according to 2020, lung was first, around 1.8 million deaths in that year, followed by colon and rectum, just below 1 million, and then liver, stomach, and among these cancers, breast was the least, almost 750,000. Now I'll talk about some basics related to cancer. We know that neoplasms are caused by non-lethal genetic damage, which causes uncontrolled cellular proliferation. So it is non-lethal, so cells can still multiply. If the cells die, then there is no cancer. So it's these cells will multiply, and there is some genetic damage. So there is DNA changes or mutational damage, and or the regulation of gene expression will be changed. So what are the genetic damages that can transform cells? The majority of our cells proliferate continuously, as we know, and this proliferation is either regulated by 2 genes or more than 1 gene. One increase the proliferation, and the other will inhibit proliferation. So there is balance usually. If we lose the balance, then cancer can happen. So for cancer to occur, there is a stimulation of genes that cause cell proliferation or down regulation of genes that inhibit proliferation. A proto-oncogenesis is normally occurring, and the stimulation of growth in controlled manner. But if there is a mutation of these genes, then there is uncontrolled growth, which means there is cancer. So if anytime there is transcript or change in the DNA, this should be destroyed by some other genes which suppress the tumor. So there are genes that stimulate the cells. On the other hand, there are some genes that suppress genes to counteract the function of oncogenesis. So if there is inhibition, if they are inhibiting these tumor suppressor genes, there is by a mutation, for example, then cells can proliferate without the breaking effect of the tumor, if the tumor suppressor genes. Other genes involved in cancer. So there are many genes involved in cancer. There are genes that regulate apoptosis. We know that apoptosis is controlled cell damage. So the damaged cell will die by other phagocytosis and other immune systems. So if the genes are opposes of the genes, for example, then these genes, if the damaged cells die then no proliferation is possible. So usually these genes frequently mutated in cancer, so cannot help in apoptosis message. And some genes also, even if there is DNA changes, this should be repaired. So if there is some DNA change or inhibition of the genes that repair the genes, then cancer can occur at the same time. Also, there is relation between host and cell, and this is related to immunity. So other genes also play a role. Now, another concept is related to free radicals. We always hear about free radicals, and we know that free radicals are excited atoms or atoms that become unstable and release oxygen. So either they release oxygen or nitrogen, and the free radicals, the free oxygen, for example, will combine with other parts or tissues or atoms in the body and can cause disease or cancer. So we need antioxidants. So this means that the free radicals, they are composed of reactive oxygen species. They can react in our body with because of different, either endogenous or exogenous systems. So overproduction of free radicals is known, as we said, to cause severe chronic disease or cancer. And some compounds work as antioxidants. These compounds, for example, vitamin E, for example, can work as antioxidant, and it's important in preventing cancer, for example. Other antioxidants are, there are plenty, and most of these antioxidants are from the environment, from, for example, our food. So our way of living, our life can affect cancer as well. So it's not all about anesthesia. Why I am talking about this? Because it's all related. So cancer occurs when there is breach to the system related to the oncogenesis, immunity, and genetics. And according to the WHO, the cancer risk can be reduced by many methods. Most of these methods is related to environment, like avoid tobacco, maintain healthy life, body weight, and eat healthy diet, including fruits and vegetables. Doing physical activity on regular periods, and regular exercise is very important. Of course, reduce or avoid alcohol, getting vaccinated, and ensure appropriate use of radiation in health care, and minimize occupational exposure. Now, another part related to surgery and anesthesia also is related to stress. Stress response to surgery and anesthesia. We know that anesthesia can manipulate the stress response as well and decrease it. So the surgery by itself can cause immunosuppression through the release of catecholamines and the stress response to surgery. The catecholamines released either from the site of injury due to the trauma, whether it is small or, of course, the more trauma to the tissue, the more cytokines, the more release of inflammatory markers, and the more stress or response to the inflammation. So this can affect immunity and can affect recurrence. Inflammation by itself is associated with tissue trauma, and of course, when cytokines are released, they should be destroyed by natural killer cells. Tumor cells are usually destroyed by the natural killer cells, but the cytokines usually they inhibit the natural killer cells. This is the point. Now, hypoxia, whether at the tissue itself or more globally, can affect cancer cells. So tissue hypoxia, how this happen? By increasing the hypoxia inducible factor 1 alpha. And this will causes proliferation of vascular endothelial growth factor. So there will be a proliferation of tumor cells due to the hypoxia. So there is different mechanism to avoid hypoxia is proliferation of these tumor cells. So high level of hypoxia inducible factor 1 alpha have been associated with poorer prognosis in a number of solid tumors. This is dramatic presentation, just presentation. This is what I have already said. Surgical manipulation and cancer recurrence. We know that surgery is the primary treatment for more than 60% of patients with cancer. However, perioperative surgical tumor manipulation causes increase in metastasis through either endothelial disruption, for example, lymphatic and heterogeneous roots, intraperitoneal seeding, also inflammatory response and immunosuppression, tissue hypoxia, as just mentioned, related to H1 alpha or VEGF, also through the hypothalamic pituitary adrenal axis and immunosuppression. Again, the same, and also in talking about the possible causes of recurrence, surgical resection might be not complete. So surgery is very important in excision of the whole tumor. So if there is some tumor cells that can go through the circulation, can invade other parts in the body and can cause recurrence. Other mechanisms of causing recurrence is immunosuppression. So the immunosuppression, whether it is due to stress response leading to increase in the survival of the tumor cells and invasion of tissue, also due to inflammation and tissue trauma that cause release of cytokines, for example, interleukin-6, that inhibit the release of the natural killer cells. Tissue hypoxia, as mentioned, also can affect cancer recurrence. Hypothermia and blood transfusion also can suppress immunity and can be a cause of recurrence. Now, in specific regarding anesthesia and anesthetic drugs, effect of anesthesia and anesthetic drugs. We know that, or whether you know or not, I'm not sure, but most commonly used anesthetic agent is propofol. So IV anesthetics, the most commonly used IV anesthetic agent is propofol. Propofol is well known as anti-inflammatory, antioxidant, and can modulate immune effect against immunosuppression. Even its chemical structure is related to vitamin E. So it does not suppress the natural killer cells in rat models in breast cancer. In laboratory studies, propofol exhibits anti-tumor effects. So propofol, the most commonly used IV anesthetics, found to be causing less recurrence than inhalational anesthetic agents. In one study or many in systematic review during studying around 10,000 patients, supported the hypothesis that total intravenous anesthetic agent propofol is more favorable for cancer survival. However, ketamine and thiopentone, other IV anesthetic agents, both suppress natural killer cells. However, it's not all consistent. Some of the studies found no change and no effect compared with inhalational anesthetics. But anyway, no study found that inhalational anesthetics better than total intravenous anesthesia, or very minimal studies. Now, regarding inhalational anesthetics, the most commonly used inhalational anesthetics, sevoflurane, isoflurane, desflurane, and rarely halothane, they all have all pro-inflammatory effects. Volatile agents found to upregulate hypoxic-inducible factors, and isoflurane found that upregulate hypoxia-inducible factor 1 alpha. And found that isoflurane increase angiogenesis, cell proliferation, and migration. However, in one single study, the effect of one of the medication, for example, in renal cell carcinoma, the opposite effect was seen in non-small cell carcinoma. In systematic review in 2016, a number of animal studies suggested a link between volatile anesthesia and the number and incidence of metastasis. In this study also, total intravenous anesthesia was associated with improved recurrence, free survival compared with volatile anesthesia. Subsequent retrospective database analysis of over than 8,000 patients undergoing colorectal surgery found an association between volatile anesthetic use and small increase in recurrence of cancer compared with Teva and propofol. The response of different cancer cells lines when exposed to serum from patient exposure to volatile anesthesia, combined regional and propofol anesthesia. They found that these cells proliferation is more when we inject or put incubated cancer cells. They proliferate higher when receiving inhalational than IV anesthetics. Other than inhalational anesthetics and IV anesthetics, other adjuvants used in anesthesia, like beta blockers, for example. Beta blockers sometimes used during the perioperative period, and maybe its action is related to suppression of the sympathetic activity or related to the stress response. So if there is depression of the stress response, then beta blockers can be beneficial. However, some other studies didn't find any difference. Opioids like morphine and oxycodone suppress the natural killer cells and may act through receptors on neutrophils. Other adjuvants like lidocaine used for local anesthetic, we know, is anti-inflammatory, has anti-inflammatory effect, reduce the level of inflammatory markers, and decrease viability of cancer cells in laboratory studies. Some studies showed improved outcome when IV lidocaine was used in lung cancer. Dexamethasone is known as anti-inflammatory. However, it's still very early to say, to recommend using dexamethasone just to decrease cancer recurrence. Oxygen by itself, administered in post-operative period, is unclear whether it improved or not. But we know that tissue hypoxia is involved in important mechanisms for angiogenesis and the tumor progression. So if there is hypoxia, there is a progression of the tumor related to, as we said before, a new vessel formation and new markers. However, giving too much oxygen also may facilitate the proliferation of tumor cells via positive effect of angiogenesis. And some studies found that giving high concentration of oxygen can increase the migration and secretion of angiogenesis in breast cancer. Regional anesthesia can decrease stress response by blocking the sympathetic nervous system. Also by sparing opioids, and we know that opioid can inhibit natural killer cells. So and also effect of the absorbed local anesthetics. All this related to regional anesthesia can be beneficial. Although some studies have found no difference. And they found it's the same, whether we give regional anesthesia or general anesthesia in breast surgery, found the same thing, 10% mortality or cancer recurrence was similar in both groups. I will just talk about some research. For example, in this study, they found that mortality was approximately 50% greater with volatile than with IV anesthesia. In this study, there was no difference. Outcome of intravenous and inhalation was the same, no difference. In this 2018 study, there also was no difference. Most of the studies are retrospective studies. In this also, propofol-based intravenous anesthesia didn't improve survival compared to desflurane in breast surgery. So in summary of the possible effect of cancer on recurrence, according to basic sciences and also studies, I am with the following, or according to my understanding, although nothing definite, of course. Inhalational anesthetics, possible harm or no effect. So either no effect on recurrence or possible harm, according to many studies. In total intravenous anesthetics, mostly beneficial. Very few studies say harm in specific cancer, but most of the time there is benefit. Regional anesthesia, according to many studies, there is likely benefit of giving regional anesthesia. So recurrence could be decreased. Intravenous lidocaine also could be beneficial. This is promising study that started and maybe this is the only prospective study, started in July 31, 2020. So 3 years ago, and expected to be completed in 2027. So in this study, they will compare volatile anesthesia and perioperative CAM related to cancer, called VABE-ORC, volatile anesthesia and perioperative outcome. So this involves many areas or centers, Australia, New Zealand, Canada, United States, and Europe, comparing inhalational volatile agents with intravenous propofol anesthesia combined with intravenous lidocaine to see which one has recurrence or not. So the primary endpoint will be propofol, tiva, and lidocaine, whether it increases disease-free survival. In summary, anesthetics and analgesics and techniques used during the perioperative period may modulate the innate and adaptive immunity system, inflammatory system, and angiogenesis, with possible impact on cancer recurrence and long-term outcome. There is growing evidence that analgesic drugs, inhalation anesthetics, intravenous anesthetics may affect cancer. So it may affect cancer recurrence. Nothing definite. And propofol-based intravenous anesthetic technique may be of benefit over volatile anesthetics. However, there is still insufficient evidence to support using one of the techniques over the other for sure. And although prospective studies are needed, it's still difficult to measure the effect of certain anesthetic drugs, as patients usually need different group of the drugs and modalities. Thank you very much. Any question, I am more than happy to answer. Thank you.
Thank you for your presentation, Doctor. If any participants have questions, they can ask now. In case there are no questions, we move to the next presenter.
Thank you. Thank you.
Thank you, Doctor.
Thank you very much. Thank you.
Now I take this immense pleasure of inviting Ms. Rafia Kanwal, University of Management and Technology, Pakistan, to deliver her speech on metastasis in renal cell carcinoma, biology and treatment. Please. Hello, Ms. Rafia, can you hear me?
Yes, I can hear you.
Yes.
Could you please make me a co-host so I can share my presentation?
Hello, Ms. Rafia. You can start your presentation.
I'm not able to share my screen because the screen is already sharing.
Okay. Give me a moment. Now you can try.
Yes. Is it visible?
Yes, it is visible.
Okay. Hello everyone, hope you're doing well. I'm Rafia Kanwal and I'll be presenting metastasis in renal cell carcinoma, biology and treatment. I'll be discussing at first the abstract, then introduction, aims and objectives, RCC biology and treatment, and at the end conclusion. So let's begin with the presentation. Alfred. Renal cell carcinoma is a heterogeneous group of cancer that results inappropriately to recent therapeutic methods and is frequently linked with uncertain clinical genetics. Heterogeneity is due to distinct cellular morphology and phenotypic profiles. Biology of renal cell carcinoma depends on histology, tumor diversity, and the biological mechanism of metastasis. Histology is the branch of biology concerned with the composition and structure of tissues in relation to their specialized function. Tumors show diversity in genetic expression and drug sensitivity. Treatment has been transformed from cytokine-based methods to targeted agent therapy against vascular endothelial growth factor and most recently to immunotherapy drugs. Before discussing the biology, mechanism, and treatment, I want to introduce the renal cell carcinoma. It encloses a diversified class of cancer attained from renal tubular epithelial cells. Renal tubular epithelial cells lines the renal tubules and is one of the 10 prevalent cancers worldwide. Radical nephrectomy, which involves removing the entire kidney along with a section of the tube leading to the bladder, the gland that sits atop of the kidney, and the fatty tissues surrounding the kidney. It can treat localized renal cell carcinoma. However, almost 30% of localized renal cell carcinoma patients ultimately develop metastasis that cannot be treated with radical nephrectomy, and it requires the systemic therapies which focuses on the interactions and relationships between groups and is linked with a high death rate. When metastasis arises in renal cell carcinoma, it usually suppresses to bone, brain, pancreas, adrenal glands, gallbladder, liver, and lymph node. Patient with metastasis renal cell carcinoma survives up to 8 months, with 50% dying within 1 year. Immunotherapy with cytokines was previously used as a quality treatment. Recent therapies used for metastatic RCC includes the targeted therapies, tyrosine kinase inhibitor, that includes the anti-vascular endothelial growth factor and anti-mammalian target of rapamycin. Some current approaches are anti-MET and anti-RET. Finally, chemotherapies includes anti-PD-1 and anti-PD-L1 and anti-CTLA-4. Targeted drugs against vascular endothelial growth factor and mammalian target of rapamycin have shown effective results and progression-free survival. Vascular endothelial growth factor promotes angiogenesis, while mammalian target of rapamycin signaling regulates cell proliferation and metabolism involved in tumor initiation and progression. Moving further to the aims and objectives of the topic, these are to summarize the biology and molecular mechanism of renal cell carcinoma and to understand the present and future directions in the treatment of renal cell carcinoma. Metastasis. So now let's discuss the biology of renal cell carcinoma metastasis in order to understand and different treatments option available and can we think of more treatment options. Almost 70% of patients with clear cell renal cell carcinoma endure mutation in the von Hippel-Lindau gene. Wild-type von Hippel-Lindau gene acts as a ubiquitin ligase and negatively regulates the expression of a large collection of hypoxia-inducible genes, controlled by hypoxia-inducible transcription factors. Wild-type von Hippel-Lindau genes causes the disintegration of the hypoxia-inducible factor. In patients enduring von Hippel-Lindau gene mutation, the subsequent rise of HIF level increases the level of the vascular endothelial growth factor. Hypoxia-inducible factor regulates several hundred genes, including vascular endothelial growth factor. High level of hypoxia-inducible factor leads to the higher level of vascular endothelial growth factor. And vascular endothelial growth factor activates the vascular endothelial growth factor receptor, activating the phosphoinositol 3 kinase AKT signaling cascade. The mammalian target of rapamycin is triggered downstream, causing the transcription of numerous tumor-promoting factors, consequently increasing cellular migration. Several tumor promoting factors are transcribed, includes fibroblast growth factor, platelet-derived growth factor, and vascular endothelial growth factor. Other transmembrane receptors may play a vital role in driving metastasis, such as MET and AXL. MET is mesenchymal epithelial transition, is a reversible biological process that involves the transition from motile multipolar mesenchymal cells to planar arrays of polarized cells called epithelia and shown to occur in cancer metastasis. MET gene encode unconventional receptor tyrosine kinases with pleiotropic functions. When signals are abnormally activated, it can initiate and maintain tumor transformation, promote cell proliferation, tumor, and angiogenesis. AXL is a member of TAM family with the high affinity ligand growth arrest specific protein 6, that is GAS6. The GAS6 AXL signaling pathway is associated with tumor cell growth, metastasis, angiogenesis, and papillary RCC is a cancer of the tubes that filter waste products that are removed by kidney from the blood. There are two types of papillary renal cell carcinoma. Type 1 is more common and grows slowly, while type 2 is more aggressive and grows more quickly. Papillary RCC has two subtypes. Type 1 disease is distinguished by mutation in the MET proto-oncogene, while type 2 is distinguished by many mutation in the SETD2. Also in the CKDN2A and TFE3. SETD2 is a protein coding gene containing 2 histone lysine methyltransferase. SETD2 plays important role in the initiation, progression, prognosis, and the treatment of solid tumors. Also, the SETD2 participate in transcriptional regulation, DNA mismatch repair, and some other processes leading to the progression of malignant tumor. And CKDN2A is a cyclin-dependent kinase inhibitor. 2A is a protein coding gene. The gene codes for 2 proteins, including the INKF4 family member P16 and P14 ARF. While TFE3 is a transcription factor binding to IGHM enhancer 3 is a protein coding gene. It encodes a transcription factor involved in the regulation of many proteins implicated in carcinogenesis, including the MET, TGF, and E-adherent. Chromophobe RCC is a rare type of kidney cancer that forms in the cells lining the small tubules in the kidney. Chromophobe RCC suggests recurrent alterations in the TERT promoter area. Point mutations in the promoter of telomerase reverse transcriptase are the most frequent non-coding mutation in cancer. TERT promoter mutations occur most commonly at 2 positions. These are from cytosine to thymine mutation located at -124 and -146 base pair from the transcription start site within the core promoter of the TERT. That accounts for the majority of the TERT promoter mutations identified in cancer. Picture here shows the mechanism of renal cell carcinoma metastasis. There are certain changes appear in renal cancer cell, and it displays the c-MET and AXL that are both involved in tumorigenesis. Due to mutation in the von Hippel-Lindau gene, subsequent rise in the hypoxia-inducible factor level increases the level of vascular endothelial growth factors. That binds to the vascular endothelial growth factor receptors on the renal cancer cell. MET binds to the AGF and promoter and promotes the RAS-TAF pathway and RAS phosphoinositol 3 kinase pathway. A signaling cascade starts when RAS converted to the RAF and then to MEK and ERK, and this ultimately goes inside the cell nucleus and binds to certain transcription factors that results in the cell growth and survival. The second pathway that is activated from RAS is the formation of phosphoinositol 3 kinase that converts to AKT and then to mammalian target of rapamycin. These results in transcription of certain genes resulting fibroblast growth factor, platelet-derived growth factors, and vascular endothelial growth factor. These binds to certain receptors present on the blood vessels, and these receptors are fibroblast growth factors receptor, platelet-derived growth factor receptors, and vascular endothelial growth factor receptor. After binding of the transcription factors to the respective receptors on the blood vessel, promotes angiogenesis that leads to the spread of cancer to other organs and promotes metastasis. PD-L1 expressed on the renal cancer cell binds to the PD-1 on activated T cell, resulting T cell receptors bind to the major histocompatibility complex present on antigen presenting cell. While CTLA-4 binds to CD80 and CD86 present on antigen presenting cell. CTLA-4 binds to CD80 and CD86 with high affinity and avidity than does with the CD80, CD24, preventing conventional T cell stimulation through CD80-86 interactions with CD28. Removal of CD80-CD86 ligands by transendocytosis result in the impaired co-stimulation of T cell via CD28, resulting in immune regulation. But in this case, there will be no immune regulation, hence tumor development occurs, leading to renal cell carcinoma metastasis. Actually, PD-1 binds to the PD-L1 and resists positive signal through T cell receptor in CD28. These immunosuppressive molecules function as brakes to regulate the adaptive immune response. This suppression of immune signals actually causes metastasis. T cells use their surface receptors to recognize the peptides presented by major histocompatibility complex. The peptides presented by major histocompatibility complex is derived from the host protein as new protein is formed due to mutations in the gene that's termed as neoantigen. Neoantigen is basically the new protein that forms on the cancer cell when certain mutations occur in the tumor DNA. Here is the molecular mechanism of renal cell carcinoma. Microvesicles bearing CD105 positive cells actually carries the phenotype of cancer stem cells. And tumor-derived microvesicles released from CD105 positive human renal cancer stem cells were shown to stimulate angiogenesis. Also, the microRNA released from such cancer cells, the angiogenesis leads to the spread of tumor and cancer cells to other sites. Some other factors also promotes angiogenesis. One of them is suppression of pulmonary metastasis of renal cell carcinoma that is due to the loss of neutrophil chemokines in lungs. Basically, chemokines are a large family of small secreted proteins that signals to cell surface G protein coupled receptor. They are best known for the ability to stimulate the migration of cells and most notably white blood cells. Chemokines produced by neutrophils in inflamed tissue amplify and polarize the immune response, and the expression of CCR7 by activated neutrophil promote the migration to lymph node where they can directly act as antigen presenting cell. But suppression will not activate the immune system and do not suppress tumor, leading to metastasis. Immune cell suppression with anti-tumor immunity causes the development of renal cell carcinoma due to their angiogenic effect. Mostly clear cell renal cell carcinoma cases have chemothripsis of chromosome 3p. Chemothripsis is a complex chromosomal rearrangement and is characterized by up to thousands of clustered chromosomal rearrangements that occur simultaneously and are localized in limited regions of the genome in one or several chromosomes. Chemothripsis of chromosome 3p leads to the loss of 3p and ultimately inactivation of von Hippel-Lindau disease tumor suppressed protein. Von Hippel-Lindau also initiates the angiogenesis process and invasion as it increases the level of vascular endothelial growth factor and by increasing the HIF. In renal cell carcinoma, VHL protein complex becomes defective and do not play its role. Consequently, HIF-1 alpha accumulates in cells and it stimulates the gene responsible for hypoxia, such as vascular endothelial growth factor and some other, such as fibroblast growth factor receptor, platelet-derived growth factor receptor, AXL, and c-MET, that are involved in the angiogenesis process. These factor receptors are utilized by different factors that binds to them at blood vessels and promote angiogenesis. Apart from it, the mammalian target of rapamycin pathway started from RAS and have an equal significant role in tumorigenesis by the loss of p53 expression or mutated phosphoinositol 3 kinase and PTEN genes. P53 is a tumor suppressor gene that stops the formation of tumor, but loss of P53 promote tumor formation. Also, the phosphoinositol 3 kinase involved in cellular functions such as cell growth, proliferation, and differentiation that is involved in the cancer. PTEN gene provides instructions for making an enzyme that is found in almost all tissues in the body. And the enzyme acts as a tumor suppressor, which means that it helps regulate cell division by keeping cells from growing and dividing too rapidly or in uncontrolled way. Now coming to the RCC treatment, FDA approved many anti-angiogenic drugs, including sorafenib, sunitinib, pazopanib, axitinib, and bevacizumab and cabozantinib. Bevacizumab is a targeted cancer drug treatment, also known as Avastin, and it is given by slow injection into vein, and it is directed against vascular endothelial growth factor. Cabozantinib is a class of medication called kinase inhibitor, and it is sold under brand name Pomtrek, and it is inhibitor of MET, vascular endothelial growth factor, and also inhibit AXL and BET. Sorafenib, sunitinib, pazopanib, and axitinib is inhibitor of vascular endothelial growth factor receptor and platelet-derived growth factor receptor. Treatment through different drugs are selected on criteria of individual patient factors. For example, patients with active immune disorders are not given the checkpoint inhibitor nivolumab. Nivolumab can worsen pre-existing autoimmune diseases. Sunitinib and pazopanib are widely used as first-line agents due to their association with the high response rates and development-free survival. In a study of pazopanib versus sunitinib, pazopanib was superior to sunitinib in terms of progression-free survival. Surgery plays a significant part in the treatment of metastasis, renal cell carcinoma. In solitary metastasis, the metastatic foci are surgically resected as a treatment option. Atezolizumab and nivolumab target PD-L1 and PD-1 respectively, and ipilimumab targets CD80 and CTLA4 and hence causes the immune activation. Similarly, bevacizumab was used against vascular endothelial growth factor, lenvatinib used against fibroblast growth factor receptor, and everolimus along with temsirolimus against mammalian target of rapamycin. Moreover, cabozantinib target multiple proteins including c-Met, AXL, and vascular endothelial growth factor receptor. Furthermore, multiple drugs can target platelet-derived growth factor receptor and vascular endothelial growth factor receptor, including sunitinib, pazopanib, axitinib, lenvatinib, and sorafenib. Nivolumab combined with ipilimumab was found to be more effective than sunitinib and showed better health and quality of life. Different drugs showed different extent of better health quality despite the undoubtable advantages of immune checkpoint inhibitors in treating metastatic renal cell carcinoma patients. Combination therapy is found to be more effective, combining anti-vascular endothelial growth factor agents and immune checkpoint inhibitors is an effective substitute that can overcome the resistance of immunotherapy and can direct both against angiogenesis and tumor microenvironment. Immune checkpoint inhibitors include atezolizumab used against PD-L1, anti-vascular endothelial growth factor receptor are sunitinib, pazopanib, and sorafenib. Patients showed better treatment results with combined therapies, anti-vascular endothelial growth factor and anti-PD-L1 that is more effective. The picture here shows the targeted therapies that are used as inhibitor. Atezolizumab is an inhibitor of PD-L1, while nivolumab is an inhibitor of PD-1. This will relieve the suppression of the immune system. Similarly, immune activation results by delivering ipilimumab against CTLA4. These are immune checkpoint inhibitors. Other targeted drugs include bevacizumab that is delivered against vascular endothelial growth factor that stops its binding to vascular endothelial growth factor receptor and prevents angiogenesis. Mammalian target of rapamycin formation is inhibited by everolimus and temsirolimus. mTOR pathway involved in angiogenesis process by inhibiting its metastasis can be prevented. Moreover, c-Met and AXL along with vascular endothelial growth factor receptors inhibited by cabozantinib As CMET involves in tumor formation and AXL involves in metastasis and angiogenesis, their inhibition will suppress the tumor genesis and prevent cancer spread. Many drugs have been used against peptide growth factor receptor and vascular endothelial growth factor receptor, include sunitinib, pazopanib, ixatinib, lenvatinib, and sorafenib, and their inhibition prevent angiogenesis process. Lastly, lenvatinib is used against fibroblast growth factor receptor, and it also inhibits angiogenesis. Finally, towards concluding my presentation, renal cell carcinoma is a diversified category of cancer that is prevalent worldwide. It is categorized into different subtypes, among which clear cell carcinoma is the most common. Different receptors are involved in metastatic renal cell carcinoma, including vascular endothelial growth factor receptor and fibroblast growth factor receptor. Proteins such as fibroblast growth factor and vascular endothelial growth factor expressed because of mutated von Hippel-Lindau gene that leads to the metastasis. Metastasis spreads to different organs, including bones, the brains, pancreas, the gallbladder, and the lymph node. The renal cell carcinoma biology differ with different histologies, which include clear cell RCC, non-clear cell RCC, and chromophobe RCC. The immune environment and molecular mediators play a significant role in the evolution of metastasis. Metastatic RCC can be treated with adjuvant therapy, systemic therapies, and surgery. Certain targeted and combination therapies involving tyrosine kinase inhibitor along with the immune checkpoint inhibitors are more effective in metastatic RCC treatment. Most importantly, targeted drugs against mammalian target of rapamycin and vascular endothelial growth factor showed much better outcomes. A study of the results of targeted drugs can develop more effective drugs for progression-free survival or metastatic RCC, both in present and in the future. Limitation is that studies are needed to elucidate the effects of possible combination therapies, whether the therapeutic agents used in sequence are more effective or first-line agents more effective. Using more broad-acting agents in combination can provide better metastatic renal cell carcinoma treatment that needs more studies. This is the reference. That's all from my side. Thank you for listening. If you have any question, you can ask.
Thank you, Ms. Rafia, for your presentation. I hope all the participants have enjoyed it. If any of the participants have any questions for Ms. Rafia, you can please proceed and ask. In case there are no questions, we would like to proceed with our next presentation. Thank you, Ms. Rafia, once again. You can stop sharing your screen now. Okay, now I would like to call upon, thank you. Now I'd like to call upon Dr. Andreana Andriotti from National and Kapodistrian University of Athens, Greece, to deliver her talk on the effect of a home-based tele-exercise training program on the quality of life and physical performance in breast cancer survivors. Hello, Dr. Andreana. Can you hear me?
Hello everyone. Can you hear me?
Yeah, we can hear you. Hi, most welcome.
Nice to meet you. Can you see my screen? It's okay?
Yeah, we can see your screen. If possible, can you please make it a full screen, because there is a text, there are text contents.
Okay, now you can see my screen.
Yes.
Yeah, you see the title and all the other things. And now I'm going to change. You see also the change?
No, we can't see the cheese. Try once again.
You see something?
No, nothing's changed still.
Let me try again to share it. I'm so late. Now you can see it, my screen.
Yeah, we can see it.
And then the change.
No, nothing's changed actually.
No.
Yeah, I think you have to do some settings in the upper. You can see highlighted text on
Okay.
the top of your PPT. Yeah.
In order not to waste our time, you can do it. You can. You have my presentation. You can up.
Okay, let me check.
Mm-hmm. Now, can everyone see my screen? Please tell me.
Yeah, we can see your screen. I want to try moving. Yes, it's moving. Thank you.
Okay, thank you.
Yeah,
I'm sorry. Hello, everyone. My name is Andriana Andriotti, and I'm from Greece. Hello from Greece. It's a very hot day. You can see, I think, you can see me or not yet.
We can see it, but please open your presentation in your computer. Yeah, now we can see. Yeah, okay.
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 I am a postgraduate student in a master who called Clinical Ergospirometry, Exercise, Advanced Technology and Rehabilitation. And this research is my master thesis entitled The Effect of a Home-Based Exercise Training Program on the Quality of Life and Physical Performance in Breast Cancer Survivors. In that point, I want to ask you, and I really want to discuss it after the presentation, if any of you did a training program during COVID-19 by remotely. Let's move on. Let me show you the outline of this presentation. At first, we will talk about medicine and exercise. Then we will see about the latest reviews and all of these about exercise and breast cancer. Then we will discuss about methodology and results of this study. And at the end, we'll have a discussion and a conclusion about breast cancer and tele-exercise training programs generally. At first, let me inform you that unfortunately, 1 in 8 women in the world will be diagnosed with breast cancer during her lifetime, and the 1 of 3 of these cases will be protection by changes in their lifestyle. Unfortunately, when a woman diagnosed with cancer suffer with a lot of impact in their body, in their soul, or in their mind. We noticed poor cardiometabolic health, sarcopenia, osteoporosis, a high feeling of fatigue, depression, anxiety, post-traumatic symptoms, painful moments, or all of these. Let's move on something on some else research. Unfortunately, breast cancer survivors don't exercise and even know anything about exercise at the beneficial points of exercising, or don't have the facilities to do it, don't know anyone profession or educated professional to do it. Let's move on and discuss about physiological, benefits of exercise in the population of breast cancer survivors. When we do exercise to this population, we notice that their body chemistry changed, their respiratory health increased, they feel more powerful and strength. And of course, the most important for me and for many physicians is that exercise do neurogenesis, which is very, very important for our nervous system and for our reactions. When we do exercise, it's like to prepare ourselves and our bodies to be ready in every stressful event that we will manage in our future. And of course, we can see more benefits of exercise, like the increase of antioxidant capacity, the regulation of sex hormones, and the immune response. Let's move on the psychological and emotional effects of exercise. We can see that the feeling of anxiety and stress, depression, and post-traumatic symptoms reduction, and overall we can improve the feeling of fear about a stressful event, feel more convenience and familiar in this environment, in stressful environments, and overall increase the quality of life. In this point, I want to tell you about the advantages of a home-based exercise program. In this situation, we don't have to do any distance or manage a difficult exercise program or a difficult environment. We feel safe to do the program in our home with our staff, with our familiar people, and it's very helpful for people who have cancer or are survivors to do it, to feel safe and familiar to a exercise training program. So the aim of this study was to determine the potential effects of a 2-month home-based supervised exercise training program on physical performance, psychological parameters, and quality of life in breast cancer survivors. Let's see together the methodology of this research. I had 13 women with breast cancer survivors, which was survivors around age 58, and they diagnosed with breast cancer within the last 5 years. The program lasted 2 months, and we have 2 sessions every week for about 8 weeks. I did reassessment every 4 weeks about physical performance, and I did assessments about psychological characteristics at the beginning and at the end of the study. In order to analyze our data, we used the GraphPad Prism statistical package. Now let's see the program of this research. In this point, I want to tell you that I was the trainer. I'm a personal fitness trainer. So I had this group of women at the same time, and we did this program. The main difference between the sessions was that in the first session we had reps, but on the second session we had seconds to measure. Also, we had differences in our rest time between exercise and between shreds. And the last one is that in the fifth week, we have different resistance in every woman. Now let's move on results. As you can see, we have an extremely difference in body mass index and waist measured. And it's better to see the figures, it's more clearly, as you can see. And the most highly significant improvement was on from 4th week to 8th week. Now let's see the differences in muscle function. As you can see, both in lower extremities, high extremities, and the core, we had significant improvements. And also we have differences in their cardiorespiratory fitness. We measured this parameter with 6-minute walk test, and we measured heart rates after the 6-minute walk test, and we both have had significant improvements. And also we measured legs fatigue and dyspnea with Borg scale, and we had changes. Let's talk about the quality of life. Overall, we had changes also in physical, cognitive, and emotional function. But the most important difference we had it on the feeling of fatigue. We didn't see anything to change in their social and role function, because we thinking about of the tele, about the remotely, and also in the parameter of pain. And at last, we can see the post-traumatic symptoms and the anxiety had an extremely change. And now let's discuss about our findings. Overall, we noticed improvement in somatometric and psychometric characteristics, and overall in quality of life. With these findings are similar some of these research, as you can see, who had cardiorespiratory fitness changes in this parameter, and also they had significant results with remote exercise training or improvement in muscle function. But in our study, we noticed that we didn't have changes in the resting heart rate because of the short duration of the study. Generally, this study was the first showing that only 2 months can improve the aerobic capacity if we had a system, if we work systematic with the population, we can notice improvement in that parameter. And we showed that the exercise is something easy and familiar for breast cancer survivors, have a low cost, and overall can improve physical and emotional the feeling of people. Let's discuss about the limitation of this study. I didn't have a control group. The group was small, and also overall the world, we don't have enough data about remote exercise training programs by educational exercise trainers, and that is a big problem, and we have to do something of this. I propose to do research with longer duration or more lifestyle changes, like change in our mindset, like meditation, mindfulness, or psychotherapy, or something like this, improve our sleep, improve our diet, or a different exercise training program. We need to motivate cancer survivors to participate in exercise training programs and be more familiar with video call technology, because we had problems with it. Ladies didn't know anything how to connect with internet and talk and act by a screen. And in this point, I want to ask you, believe that it's our future, what we can do, next steps or something to help me or the cancer survivors to improve their lives. And this is the references, and thank you for your attention.
Thank you so much, Dr. Andriana, for your wonderful presentation. I hope all of the participants would have liked that. Also, we do have a question for you from Dr. Julie. Yes, Dr. Julie, you can go on. You can ask the question.
I'm sorry.
There we go. I'm sorry. I think I was still muted. So I was wondering if you started the exercise. Can you hear me okay?
It's you. Sorry.
I don't know why it's breaking up. Here we go.
Can you hear me?
Yes. Can you hear me okay?
Yeah, but I saw the camera. I'm sorry for this, because
nope,
the
that's
system...
fine.
Okay.
So I was wondering, was this treatment was this exercise, was this done during the, like, say, chemotherapy or after treatment? And if so, how long after treatment did you start working with the women?
Mm-hmm. This program was after treatment. The ladies was survivors, and as we can see, if I open the presentation, we had it during 5 years. They had 5 years. I'm sorry for my English. I'm not very. I'm not speaking very well.
No,
sorry
it's
for
fine.
that.
It's fine. You're good.
Thank you.
And I like the idea of what I've seen some institutes here in the US do is start meditation, as well as breathing exercises, even during the chemotherapy treatment. And I mean, it's still, you know, research in progress, but I'm hoping that's going to be promising. So even during the treatment period, having some techniques to bring down the stress level, bring down, you know, increase mental health. And then, of course, you can't start exercise right, you know, during chemotherapy or directly after. So that's why I was wondering, is like how many years after? So thank you.
I really can I answer that. To that, I really believe that it's must to do something with their psychology, because the ladies suffer. I had 13 women, and we talked all the time on the phone in order to put them and pick up them to be in the exercise training program for about 2 months, and so now contact us and the study had such results. We had contact, and we communication every week for about 2 years. And
Oh, wow.
that
Yeah.
one want to really help in Greece. We don't have a system to support them and give them with situation about cancer or during the chemotherapy or after. And we try, all the professionals, to do something, but as you increase, the things are so close minds, and they believe when have a diagnosis about cancer that they will die. And we want to change that. It's important. Thank
I
you.
agree. Having the awareness and thank you for your research. Very promising.
Yeah, thank you so much. Bye.
Thank you, Dr. Andriana, once again for joining us and having a lively discussion. Also, now I would like to propose a short break of 5 minutes, just 5 minutes, and then we will be having our next presentation with Dr. Judy. Thank you.
Am I the next presentation up, or should I take down my slide share?
Hello all, welcome back. Now we would like to proceed with our next presentation. Now I'd like to call Dr. Julie Yates from University of Arizona, USA, to deliver her talk on high Cavalian 1 expression in African American women with treatment 9, early stage triple negative breast cancer. Hello, Dr. Julie.
Hello,
hope
can
you-
everyone hear me okay?
Yeah, we can hear you. Most
And
welcome.
can you see the slides?
Yeah, we can see the slides as well.
Okay. Hello, everyone. Here it is. I'm going to say it's almost 5:30 a.m., so the sun is just coming up. I'm in Phoenix, Arizona. It's going to be about 120 degrees Fahrenheit here on Saturday. So I believe we're going to be the hottest state in the US come this weekend. Let's see here. Okay, so this work was done in collaboration with ASU, as well as Translational Genomics Research Institute, which is also in Phoenix, Arizona. I'm not able to move there we go. Okay, so I wanted to talk about breast cancer. So in the US, it's one of the most diagnosed cancers in women each year. It's over 280,000 new diagnoses, typically women between the ages of 55 and 65. And about 5 to 6% of the cancers each year are in men. 5 to 10% are breast cancers diagnosed are inherited genetic mutations. The rest are sporadic, having no family history. There are risk factors involved. A woman's lifetime risk of developing breast cancer is, as Andrea mentioned earlier, is expected to be 1 in 8. There are non-modifiable risk factors such as your age, your family background, genetics, your breast density, how long you're in sort of a hormone phase, whether it's early menarche to late menopause. But there are some that are modifiable. How many children you have, if you breastfeed, what is your exposure to hormone replacement therapy or contraceptives, alcohol use, obesity, and exercise. So in the United States, we have a health disparities. So every year, the American Cancer Association puts out breast cancer facts and figures using SEER data throughout the states. And historically, this pink line here is Caucasian women. The light pink is African American. Historically, Caucasian women have the highest incidence of breast cancer. However, when we look at mortality, there is a 40% difference here in mortality in African American women compared to Caucasian women. We also know that African American women tend to be diagnosed at an earlier age and at a later stage, and are more likely to get a more aggressive form of breast cancer called triple negative breast cancer, and that's what I research. So triple negative breast cancer accounts for 10 to 15% of all breast cancers diagnosed. We call it triple negative because it lacks estrogen receptor, progesterone receptor, and HER2 receptors. So therefore, it's unconventional or it's unresponsive to conventional hormone therapy. So it's a very aggressive type of breast cancer. Like I said, it's early age of onset, higher tumor grade, common mutations in the tumor suppressor genes such as P53 or BRCA1. It's also a highly proliferative cancer. So sometimes we'll call it an interval cancer. It develops in between your yearly mammograms. So there are also known, thanks to Chen and Pientenpohl, we know that there are 6 different molecular subtypes of triple negative breast cancer. And now these align with tumor biology, as well as can be predictive of disease. We do have treatment options for metastatic TNBC. A few years ago, I would have only had 1 or 2 bullets here. It would have just said surgery, radiation, and plus or minus chemotherapy. In the last 5 years, it is exciting that we've been able to add in PARP inhibitors, immunotherapy, antibody drug conjugates, and hopefully there will be more. And I think with this subtyping, molecular subtyping, looking at the genes driving each of these subtypes of TNBC is only helping our understanding of the disease. So our study was to look at any genetic alterations that might be contributing between the African-American women and Caucasian women in the US. So this was a multi-institute, multi-year study started by Dr. Lisa Bombeck-Reardon at the University of Miami. She came to TGen, which is here in Phoenix, and then along with Dr. John Carpton at TGen also. And all the samples, these are FFP blocks, so formalin fixed, paraffin embedded tumors, were all collected at the University of Miami. So I wanted to look at the very earliest stages of triple negative breast cancer to see what gene alterations we could find. So we looked for lymph node status, node 0, estrogen, progesterone, and HER2 negative, so they're all TNBC, and having no prior exposure to chemotherapy or adjuvant therapy. So before this is all from biopsy before any treatment occurred. And it is a small sample size, however, it's still very significant. Again, this is 10 to 15% of all breast cancers are TNBC, so it's already a smaller subset. So we were able to get 10 African-American samples, 13 Caucasian, all with matched adjacent controls. So our understanding of breast cancer is that we do have molecular subtypes now that help with, again, with that, our predictive and prognostic of the disease. So something like a luminal A type breast cancer is an ER positive, PR positive, and we have good treatments for that compared to where our tumors are going to lie, which is in the basal-like breast cancer molecular subtype, which are ER, PR, and HER2 negative. So this, using the PAM50 gene signature, you can profile the breast cancer tumor. So we did that with our sample set, and we see that the Caucasians, as well as the African-American samples, are both predominantly basal-like breast cancer, which is to be expected. So next I wanted to see where did the sample set lie within the triple negative breast cancer molecular subtyping. So thanks to the work done by Chen and Pientenpohl, that we again have our 6 different subtypes of TNBC. Chen also it's a free web-based tool that you can upload your expression data to. You don't have to buy any software, and it will differentiate your TNBC tumor samples into their molecular subtypes. Mayer et al. Did a paper where they looked at a larger data set of TNBC and to look at the common distribution. So when I used our samples, the Caucasian sample set was very similar to the larger data set distribution, with the most being basal-like 1. However, when we looked at the African-American samples, they were very different distribution, highly in immunomodulatory, mesenchymal, and basal-like 2. So immunomodulatory is immune-mediated. The basal-like 2 is a highly proliferative, it's growth factor driven, and then the mesenchymal-like, which is involved in differentiation and crossing the epithelial mesenchymal transition. go. So using those same samples, we isolated RNA from the FFP scrolls. I ran an LMAC breast cancer disease specific array specifically because we had such low sample volume. This platform was very good for liquid biopsy or as we had FFP scrolls. So what we see is 190 differentially expressed genes between the African American and Caucasian samples. So green are downregulated, red is upregulated. I used those genes, that gene set, the 190 differentially expressed genes, loaded into GeneGo, which is a pathway enrichment analysis. So how do these genes work together and what pathways do they affect within the cells? And it was very high for cell proliferation, the cytoskeletal remodeling. So I had to, I would have loved to research all 190. However, I needed to, right? But I wanted to pull out some candidate genes. So looking at the top 10 pathways, I wanted to see what genes were involved that continuously were involved in each of the 10 pathways. So I chose caveolin-1, which has been known to be highly expressed in some cancers and involved in cell proliferation, as well as FOXO3A, TCF4. Both are involved in Wnt activation and cell proliferation. And since TNBC is highly proliferative, I thought these were good candidate genes to further research. So in order to validate our findings, I isolated from a separate set, isolated this RNA from the scrolls. I performed a gene expression array assay, and the one that came up the most consistently was caveolin-1 as being mRNA highly expressed in the African American samples compared to the Caucasian samples. So our hypothesis was that CAV1 is differentially expressed in African American women with TNBC. So what is CAV1? It's an integral part of the protein membrane. It's highly regulated by cholesterol. It's involved in membrane trafficking, proliferation, and migration. So it gets tricky because there's a lot of literature that says it's a tumor suppressor, say in colon, ovarian, and some ER positive breast cancers. And then it's conversely, it's associated with poor prognosis in prostate, lung, and lung cancer. So the difference seems to be in the tumor subtype and location. So that's the first thing we wanted to look at we acquired an independent sample set, 13 African American samples, 10 Caucasian, all with early stage TNBC. And these are all FFP blocks. So we created a tissue microarray. So each dot on the slide is going to be representative of one tumor and or its matched control. So we stained with caveolin-1 and we wanted to look at where it was located in the cell. So there was no difference between the two groups. However, we were able to see that it was expected high in the cytoplasm and plasma membrane. But when we looked at the H-score, which is looking at the stain intensity on the actual tumor in percentage of the tumor, we did see that in protein, at least, high protein level expression was significantly higher in the African American cohort compared to the Caucasian. So I also used this independent sample set to confirm that mRNA was indeed higher in the African American versus Caucasian. So next I moved to a cell line panel. So we which has been, the TNBC cell lines have been well characterized. We know what TNBC subtype they are. We know what their phenotype is. And so here I have our mRNA expression. I'm using cell lines 231, 1806, BT549, and 157s, which are highly proliferative. And here's our mRNA expression of caveolin-1, as well as protein expression. So each of these are high expressors of CAV1, and I wanted to bring back that TNBC pie chart we had. So the differences between Caucasian and African American samples. So I was able to pull in let's see here, there we go, a basal-like 2 cell line, a mesenchymal cell line. Unfortunately, at the time, we didn't have an immunomodulatory cell line, but you can see that, again, CAV1 is highly expressed both in protein and mRNA. So I chose to do some CAV1 silencing. So I used siRNA technology to knock down our mRNA expression of CAV1. And then this is our validation that shows that it was knocked down in protein. I ran a cell proliferation assay on these cell lines, on the 4 cell lines. In the green is control, and the dashed line is the ones that are knocked down with where CAV1 is knocked down. In each of our 4 TNBC cell lines that were high expressors of CAV1, we were able to knock down cell proliferation. So it's a very, it's a study that's still in progress. So right now, what we have for our summary is that in early stage node 0, we have 190 differentially expressed genes between African American samples compared to Caucasian. They're mostly comprised of the basal-like 2 immunomodulator mesenchymal molecular subtype. We know that the top pathways that are driving these tumors are cell proliferation, cytoskeletal remodeling, and we've identified caveolin-1 as being a potential player in that. So I also validated this first set with an independent cohort, and we again found high CAV1 in the African American samples when compared to Caucasian, in vitro and in vivo and in vitro. And then we were able to silence CAV1 expression, which decreased cell proliferation in all of the in the 4 TNBC cell lines. So these observations suggest that it could be caveolin-1 could be a contributor to the health disparity of this more aggressive phenotype that we see in African American women. CAV1 could also be a potential therapeutic target. It's been certain research has been done in other cancers looking at that. But obviously, with the small sample sets, we need further validation in either larger data sets, such as TCGA, and we also need more samples from minority women. So this is my mentor, Dr. Lisa Bombeck-Rudin, that started this project, Dr. John Carpton from TGen, our group there, our support, and then also I wanted to thank the patients who donated their tumor and control samples for research purposes. And if there's any questions.
Thank you for your presentation, Dr. Julie. If any presenter have any questions, you can ask now.
Thank you.
Thank you, Dr. Julie. In case there is no questions, we move to the next presenter. I call upon Dr. Tinatin, Tojua Clinic, Georgia, to deliver her talk on the role of stereostatic radiosurgery for brain metastasis from primary breast cancer.
Hello, can you hear me?
Hello, Dr. Tinatin.
Okay, if you can see my presentation, can I start?
Yeah, doctor, you can start now.
Okay. My name is Tinatin Alverdashvili. I'm a radiation oncology resident from Tbilisi, Georgia. And before I start my presentation, I would like to thank conference organizers for this chance to be here today. It's such an honor for me. And also I would like to thank my mentor, Professor Michael Baramia, who is the co-author of my study. Our study is about the role of stereotactic radiosurgery for brain metastasis from primary breast cancer. Before I start excuse me. Okay. Before I start talking about our study, I would like to briefly review the main concept. Now, stereotactic radiosurgery is a technique that helps us to administer precisely directed high-dose irradiation that tightly conforms to an intracranial target to create a desired radiobiologic response while minimizing radiation dose to surrounding healthy tissue. So this technique exploits the fact that the radiation tolerance of normal tissue is volume dependent. Stereotactic refers to using a precise three-dimensional mapping technique to guide the procedure. Now, compared to conventional radiotherapy with standard 1 to 2 centimeter treatment margins, allowing for patient movement and setup errors, stereotactic techniques reduce complication risk for any radiation dose delivered by minimizing or eliminating normal tissue treatment margins. Radiosurgery, we use term radiosurgery when all of the irradiation is done in 1 to 5 sessions or fractions. And when irradiation is done in 6 or more fractions, we use the term stereotactic radiotherapy. Like every other form of radiation, stereotactic radiosurgery also works by damaging the DNA of the targeted cells. Then the affected cells lose the ability to reproduce and grow. And with optimal treatment, the abnormal tissue becomes inactive and gradually shrinks. Stereotactic radiosurgery can be delivered with gamma knife, as well as modified LINAC radiosurgery systems, including CyberKnife and image-guided radiotherapy systems. It can also be delivered with thermotherapy and proton beam systems. In our institution, we have a LINAC-based radiosurgery system. We use image-guided radiotherapy, and all of our patients are treated with the machine that you can see on this picture. When we think about the epidemiology, breast cancer is the second most common origin of brain metastasis after lung cancer. This graph is from the Handbook of Clinical Neurology. Now, when we think about primary histology, where the brain metastases are coming from, it's commonly seen among patients with metastatic lung cancer, as well as breast cancer, also renal cell carcinoma, melanoma, as well as even more rarely seen prostate cancer and GYN malignancies. Brain metastasis in breast cancer is commonly found in patients with an advanced stage of the disease, and it has poor prognosis because the blood-brain barrier is thought to be the major obstacle to delivery of many drugs in the brain. For example, targeted therapy or systemic therapy. So the main treatment options for brain metastasis are surgery, stereotactic radiosurgery, and the whole brain radiation therapy. These three are the gold standard for brain metastasis. This is an ASTRO clinical practice guideline for limited brain metastasis. And when we say limited, we mean that a number of brain metastases are up to 4. When ECOG performance status range from 0 to 2, and the largest brain metastasis is less than 4 centimeter, like in our study, the largest brain metastasis was 3.7. So in our situation, a single fractionated stereotactic radiosurgery is recommended, as well as multifractionated stereotactic radiosurgery. And this is for extensive brain metastasis, when ECOG performance status is from 0 to 2, and largest brain metastasis is less than 4 centimeter. In our study, the number of brain metastasis range from 1 to 7. So in our case, the single fractionated stereotactic radiosurgery was recommended for extensive brain metastasis, as well as multifractionated, and also whole brain radiation therapy was an option. It is known that for limited brain metastasis, stereotactic radiosurgery is better option than whole brain radiation therapy. But now when we think about when we have 5 or like 5 to 10 brain metastasis, the question is, can we use stereotactic radiosurgery? So this is a study published on Lancet Oncology. And this study was done, there was 3 groups of patients. In first group, there was patients who had 1 brain metastasis. On second group, was patient who has 2 to 4 brain metastasis. And on the third group, there was patients who had 5 to 10 brain metastasis. And stereotactic radiosurgery was done for all these patients. And we see that median overall survival was better for patients who were in first group, but median overall survival was similar for patients in group second and in group third. So this study shows that stereotactic radiosurgery is as effective for 5 to 10 brain metastasis as it is for 1 to 5. So we can use stereotactic radiosurgery for brain metastasis up to 10. This is an ASCO clinical practice guideline, which said that for patients with an ECOG performance status of 0 to 2 and up to 4 brain metastasis, stereotactic radiosurgery is strongly recommended. And for patients with an ECOG performance status of 0 to 2 and 5 to 10 intact brain metastasis, stereotactic radiosurgery is conditionally recommended. So this is an NCCN guideline for brain metastasis. As I have already mentioned, stereotactic radiosurgery is preferred over whole brain radiation therapy for limited brain metastasis. Also, the maximum marginal doses from 50 to 24 gray based on tumor volume is recommended. And we should consider fractionated stereotactic radiosurgery for brain tumor when it is more than 2 centimeters, or in situations where a single fractionated stereotactic radiosurgery exceeds normal tissue constraints. Also, the most common multifraction stereotactic radiosurgery doses include 27 gray in 3 fractions and 30 gray in 5 fractions. So small lesions which are less or equal 20 millimeter can be treated with up to 24 gray. Those that measure between 21 and 30 millimeter might receive 18 gray. And those that measure between 31 and 40 millimeter might receive 15 gray. So let's talk about our study. We did a comprehensive retrospective analysis on 31 patients treated with stereotactic radiosurgery for brain metastasis from primary breast cancer during 2020 to 2021. Median age of patients were 58. Age range from 40 to 76, and our study aim was to assess treatment response to evaluate the impact of stereotactic radiosurgery on symptom resolution, and also to determine its effect on improving a patient's quality of life. The most common symptoms that our patients had were alterations in cognition and mental status, also headaches and seizures. Other less common symptoms were nausea and vomiting, also deficits in sensation, motor function, speech, and inner vision. Karnofsky performance status for all patients was more than 70%, and ECOG performance status was 1 or 2. We use contrast enhanced MRI for all these patients, and then we fused MRI images with CT images from CT simulation to create an optimal treatment plan. Results was that we see a number of brain metastases range from 1 to 7. Most of the patients, 10 patients has 1 brain metastasis, and 7 brain metastasis was seen in only 1 patient. Also, the size of brain lesions range from 2 to 37 millimeter. And as you can see, most of the brain lesions were smaller than 10 millimeter, and only 5% was from 30 to 37 millimeter. Treatment was administered using single fraction and fractionated stereotactic radiosurgery. For single fraction doses, we used 15 from 15 to 24 gray in one fraction, and multi-fraction doses were 27 gray in 3 fraction or 30 gray in 5 fraction. Also, I want to mention that prophylactic corticosteroids were administered in all patients to prevent side effects. Talking about side effects were very rarely seen in our patients. The most common side effects was fatigue. Also, in some patients, we see peritumoral cerebral edema, which was reversible, and also scalp and hair problems such as red, irritated, or sensitive scalp at sites where the device was attached during the treatment, and temporarily lose of small amount of hair. This is a clinical case of one of our patients. She is a 70-year-old female with solitary brain metastasis, and stereotactic radiosurgery was performed at 22 gray in 1 fraction, and you can see the results. The first MRI is done on June 1st, 2020, and the second MRI was done on April 10th, 2021. And as you can see, the metastatic lesion is significantly smaller than it was before a treatment. Also, this is the same patient. Analysis of treatment response, symptomatic improvement, and quality of life assessments revealed positive trends. As you can see, complete symptom resolution was seen in 74% of patients, and 26% of patients had significant improvement. Some survival rates was also very good. 1 year survival rate was seen in 58% of patients, which is in our study 18 patients. 2 year survival rate was seen in 29% of patients, which was 9 patients, and unfortunately for patients, overall survival was less than 1 year. In conclusion, this retrospective study provides compelling evidence to support stereotactic radiosurgery as an effective treatment for brain metastasis from primary breast cancer. And this outcomes highlights its contribution to treatment response, symptom resolution, also its improved quality of life, and advocating for its integration into comprehensive management strategies. Thank you for your attention. If you have any question, you can ask me, or also feel free to contact me via my email that you can see on this slide.
Thank you so much, Dr. Zinatin, for your valuable presentation. I hope all the participants have enjoyed. If any of the participants have any questions, they can feel free to ask. If there are no questions for now, you can contact Dr. via her given email. Thank you once again. Now we would like to move on to our next presenter, Dr. Huan Gui from Guizhou University, China, to deliver his talk on anti-TNFR2 enhanced anti-tumor activity of a new stimulated dendritic cell vaccine in a mouse model of a colon cancer. Hello, doctor. Can you hear me? Hello, doctor.
You see, hello.
Yeah, we can hear you. Hi.
Can I start?
Yes, you can start.
Can you see my slide?
Yes, we can see your slides.
Hello, I'm glad to be here introduce my presentation. Let me introduce myself. My name is Gui Huan. I'm from the Department of Biomedicine Science of Guizhou University in China. And my major is neurology, immunology, and oncology. First, my subject is title is the anti-TNFR to enhance the anti-tumor activity of a new HMG-N1 or 3M052 stimulated dendritic cells vaccine in the mouse model of colon cancer. First, I will briefly introduce the research background. Hello? The global incidence of colorectal cancers has been on the rise, making it the third leading cause of cancer-related mortality worldwide. And we all know the immunotherapy has been emerging as the therapeutic modality for the advanced tumor. And among them, the dendritic cells are specialized presenting cells that capture and present antigen to native T cells, introducing their activation. While the vaccines obtained by co-culturing DC with the specific tumor antigens have shown some therapeutic effect on tumors. The existing DC vaccine has limited efficacy in achieving a cure. The development of effective combined immunotherapy using new DC vaccine is therefore of great significance for cure tumors. And in our experience, we use the 3 drugs. The first is high mobility family nucleosome binding domain protein 1, abbreviated as HMG-N1. It is a toll-like receptor for agonist protein that functions as an alarming signal, facilitating the activation and migration of DC. Thereby inducing polarization towards type 1 helper T cells mediated immune response. And the second drug is 3M052. It is a novel agonist that selectively activates disease by specifically targeting both TLR7 and 8. Thereby enhancing the body ability to generate a robust immune response. And the 3 drugs is tumor necrosis factor receptor 2. The TNFR2 is not only expressed on a variety of tumor cells, but also highly expressed in the tumor microenvironment. The presence of TNFR2 positive Tregs can facilitate primary tumor growth and metastasis, while anti-TNFR2 antibodies can effectively inhibit Tregs to achieve immune tolerance separation. So our research aim is whether the combination of DC vaccine activated with HMG-N1 and 3M052 along with the anti-TNFR2 immunotherapy exerts inhibitory effect on tumor growth in colorectal cancer remains to be determined. Additionally, it is worth investigating whether the combination immunotherapy suppressed the tumor growth via cell factor pathway in colorectal cancer. We used some novel method. For the first, we used the tumor cells fraction with 4 antigens, which obtained by repeat repeated frozen zone, and the other cells is from the immature disease, which harvested from the bone marrow in femur and tibia, and which will be stimulated with the HMGN1 and 3M052. The two cells will be the two section will be co-activate in the DC, which will be making with as a DC vaccine, and then the tumor cells antigen sensitive DC vaccine will be using in a mice to activate the T cells, and the anti-TNFR2 antibodies will be using in mice to inhibit the Treg cells. So this is a combination novel DC vaccines. And this is the follow chart we use. First, we used the CT26 tumor cells to incubate with the in the Babisi mice, and then we use the antigen DC vaccine, or with or without the stimulate. And then we found that the HMGN1 and the 3M052 synergistically promote the disease maturation and the inflammatory effect in vitro. We can see that the DC with the N1 and the 3M can markedly increase the CD80 and the CD86 positive cells. And then we found that the TNF alpha and the IL-12 expression level will be increased. And then when we use the CT26 agent loaded DCs, we can find the same effect. In the feature A, we can see that the CD80 positive and the CD86 positive cells were markedly increased. And the rate of TNF-alpha expression level and the IL-12 levels were increased. And then we use the novel NMO antigen DC vaccine in combination with anti-TNFR2 antibodies. Achieved a complete eradication of colon cancer in mice. We can say that the tumor volume is lowest in antigen DC vaccine and the anti-TNFR2. And then we can see that the novel DC vaccine with N1 and the 3M and the combination with the anti-TNFR2 have a highest survival rate, but the body weight have no significant change. And in rechanging experience, we found that the novel vaccine and the anti-TNFR2 antibody facilitated the induced induction of the immunological memory in mice, because we injection the 41 41 cells in the left of mice, but they have no tumor can growth. And then we determined the novel NMO agent DC vaccine combination with anti-TNFR2 antibodies induced anti-tumor CD8 positive and IFN gamma positive cells and inhibit the Treg cells. And this is the determining experience. We can say that INF gamma positive cells in CD8 have the highest rate. So we conclusion that the first conclusion is a novel DC vaccine has been successfully prepared and demonstrated the synergistic stimulation of HMGN1 and 3M052 in promoting the maturation and activation of dendritic cells, and thereby enhancing the producing of pro-inflammatory cytokine IL-12 and TNF-alpha. Consequently, this leads to the activation of an effective immune response. And second, the novel DC vaccines in conjunction with the anti-TNF-alpha antibody demonstrate the efficacy in eradication tumors in murine models. And the third, the combination of DC vaccine and TNFR2 antibodies induce the joint resistance, leading to the development of immune memory in mice. And the immune mechanism of the new DC vaccine and the anti-TNFR2 antibody combination thereby involved inducing anti-tumor T cells response, while suppressing immune tolerance in mice. Thank you for your attention. If you have any question.
Thank you, Dr. Huang. Thank you for your presentation.
Thank you.
Yeah. If anybody have any questions, you can ask now. In case there is no questions, we move to the next presenter. Now I would like to call Dr. Ramona Fayazfar, University of Ontario Institute of Technology, Canada, to deliver her talk on a highly sensitive biosensor for the detection of cancer, TP53 gene mutation based on aligned carbon nanotubes, gold nanoparticles, nanocomposite electrode.
Okay, so thank you so much, Joel. Very nice to meet you all. Let me share my screen and we can start from there. Okay, so I'm trying to find. Could you please confirm if you can see my screen, Joel?
Yes, doctor. Please
okay,
go on.
awesome. Okay, awesome. Let me just. Okay, so welcome to my talk today. Very nice to meet you all. I'm gonna just talk about a little bit from just another perspective today, which is about the electrochemical biosensors for cancer diagnostic. and it's based on hybrid advanced nanocomposite material. But let me just briefly introduce myself. So my name is Ramona. So I got my PhD in material science and engineering, and I'm currently working as a professor in Department of Mechanical and Manufacturing Engineering in Ontario Tech University in Ontario, Canada. So, just my research expertise and experience expand a variety of multidisciplinary areas, but one of the areas that I would like to discuss today is, just 3D printed bio-nanosensors and wearable sensors for point-of-care diagnostic and health monitoring. Okay, so let me just show you a brief introduction about the nanotechnology and biosensor, and a little bit show you some stat about breast cancer, and I go to some case study in my group, and then show you the future vision of my lab. So, the global nanotechnology, just market size is expected to reach $290 billion USD, the CAGR of 18% from 2021 to 2030. So you see this, just huge number here. So, but why? So, because nanotechnology market, is able to reduce manufacturing costs, and it's cost effective, right? So it's design flexible, and it can manufacture a smaller, lighter, and more functional devices such as biosensors, right? And nanotechnology today find application in many areas. But again, I'm gonna focus today on treatment of cancer, which is very important, right? Let me just show you some stat here. If we divide the nanotechnology market by type, application, and region, by type, you see in the picture, nanocomposite segments dominate the nanotechnology market, nanocomposite material that we're gonna explain more in the following slides. And based on application, the healthcare segment will grow the highest in the market. And based on region, the Asia-Pacific segment will grow the highest rate, right? So up to 40%. But here in North America, the US government allocated $1.4 billion for the national nanotechnology initiatives. And the Canadian government as well also invested more than $640 million in nanotechnology research only over the past decade. So it shows the importance of this field of study. And but what is the market driver for nanotechnology? So it's the healthcare sector, right? So I mean, the key driver is rising use in medical diagnosis and imaging, and this is what I'm gonna focus today. So, but let me just talk about the nanobiosensor. So, a sensor is defined as a device that is able to, just detect the presence of analyte in a sample and quantify this, right? We have a variety of sensors. For example, we have piezoelectric sensor, optical sensor, thermal sensor, right? So depending on the sensor signal utilized. But today I'm going to focus on electrochemical sensor, which is a unique category of sensor, and it works based on the electron transfer and different techniques, right? But it can detect the biological elements and as a diagnostic component, right? And we have an electrode, we have the different activity, and this electrochemical biosensors can show you a signal. But if we can take advantage of simultaneously, of nanostructure and electrochemical sensor, so we can, have emergence of sensor with high sensitivity and decomposition power to detect cancer. But for the role of nanostructure here, so the electrode surface for biosensors, the electrode surface design and engineering play a key role here in the decomposition efficiency of sensor, right? So, we have a variety of nanomaterial. We have carbon nanotube, nanowires, nanoparticles, right? But I'm going to focus on carbon nanotubes, which is the darling of nanotechnology board. And NASA currently, just is working a lot with carbon nanotube material. But why? Because this type of nano material has unique properties. They have excellent electrical conductivity. They have very high mechanical property, just electroactive surface area, high surface area. So it's a, just one of the best candidates as the nanocomposite electrode. But in nanocomposite, I mean, we can take advantage of different combination of different nano scale material, right? So, and we can have, dramatic improvement in property compared to micro or macro structure. And let me just explain more. And before that, show you some stat about cancer that definitely you know better than me, definitely. So, just look at the stat here. So, cancer is one of the leading reason for alarming global deaths, with 19 million reported cases and nearly 10 million deaths in 2020. So the stat is shocking, right? And just the most common cancers are breast, lung, colon, and rectum and prostate cancer, right? But the around 1/3 of deaths from cancer are because of the tobacco use, unfortunately, high body mass index, alcohol consumption, lack of physical activity, right? So there are different reasons. But look at the picture. According to estimate from the World Health Organization in 2019, the latest report, cancer is the first or second leading cause of death before the age of 70 years in 120 countries, and it's ranked third or fourth in a few further 23 countries. So you see, this number shows us this is an urgent need to do something, right? So, but let me focus on breast cancer, which is the main focus of this conference. So again, look at all the pink areas in the picture. So according to latest global cancer stat of International Agency for Research on Cancer, breast cancer occurs with the highest incidence, right? It means it becomes the most commonly diagnosed cancer throughout the world. And for incidence only, in the year 2020, about 2 million new cases of breast cancer have been diagnosed. And among whom 0.68 million deaths occur, which is 11%, right? And the age standardized ASR of breast cancer incidence in the world will gradually increase, right? So look at the pink area. So you see it's estimated by 2050, the ASR of breast cancer incidence in female will be 59 per 100,000, which is an increase of 32% compared with 2019, which is so sad, right? So just the breast cancer occur mostly in females, but there is still evidence that is also occur in males because of hormone disorder and other symptom types. And it's that the ASR report shows that this breast cancer incidence in male gonna higher 1.74% compared to 2019 in 2050. So again, it shows us the urgent needs right here. But many cancers can be cured if detected early and treated effectively. I mean, protection is better than cure, and early stage detection of cancer is essential to ensure its diagnosis before they become incurable, and we can save more and more people's life, right? So here the function of biosensor gonna show up. So biosensor are widely used to detect and monitor biomolecules and just detect different analytes. But look at the picture. So the market for biosensor as 2021 was $27 billion USD, and is expected to expand $49 billion USD by 2030. You can see this huge money right here. And look at the chart on the right side. So the biosensor, as I mentioned, that there are different categories, but electrochemical biosensor, they take the share of 79%, which is the most highly used rate of sensors. So Because of that, I'm going to focus on electrochemical biosensor, which is promising, right, based on the electrical property, optical activity, catalytic performance to detect cancer, the application of carbon nanotubes, metal nanoparticles, and quantum dots. There are different types of material, right? So they are promising. And it's important to select the most appropriate type of nanomaterial to prevent diagnostic bias. But I focus on a combination of carbon nanotube and metal nanoparticles to develop advanced nanocomposite material. But as I mentioned, why carbon nanotubes among just a lot of material that have in this world? Because carbon nanotubes are ideal electrode for advanced biosensor because they have high conductivity, electron transfer rate, fast response time, right? All of this property, just can can make us able to build highly sensitive sensors to detect cancer, right? And if we add gold nanoparticle in a hybrid configuration on carbon nanotubes, then we have, we can enhance the property, the sensing property, right? And we can build very high sensitive electrodes for, for biosensors. Okay, so the challenge is design and fabricate this modified electrode based on this hybrid material by using low cost, less energy consuming and sustainable nanomanufacturing techniques. And we address this one, right? So in my lab, we use different techniques. I don't want to go in detail to different techniques, but the main technique is electrochemical techniques that we use to make this electrode as biosensor material to detect cancer. But let me just show you quickly some of the result case study that we already worked in my lab. So if you are interested, you can check our publication. But look at the pictures. So we just fabricated vertically aligned carbon nanotubes, and it enhanced its electrochemical activity. And look at this, that we decorated this carbon nanotube with gold nanoparticles, nanoflowers, different unique shape of gold nano structure for the very first time. And by just simple controlling of process parameters, which is critical toward future nano devices and biosensors, we make this electrodes, right? So, but we developed this advanced composite electrodes. Now it's, we want to detect cancer, but how? What we did, and, how it works at all, that use, for example, biosensor to detect cancer. So it's based on the DNA impedance, biosensor for detection of cancer. But how it works? So in DNA hybridization electrochemical biosensor, so look at the picture. We have the detector string, which is fixed on the electrode surface. And if target DNA is present in the sample, for example, in the solution, and hybridization occur, a measurable electrical signal is generated on computer, and we can detect and just analyze and interpret this signal. So I mean, it's based on the pairing of two complementary strands, right? The target DNA, I mean, the strand containing the complementary sequence of the identifier strand, right? So this system, in simple word, just work based on hybridization reaction between a probe immobilized on the sensing surface, on the electrode surface, for example, carbon nanotube that I showed you, and the complementary sequence or the mismatch one in the solution. So they're gonna, just pair on the surface of the electron. On the top picture, if you can see my mouse here, let me see if it works. Yeah, so on this picture, so you see we have one probe, another strand, pair with this, and then we have a signal in computer, and then we can interpret this signal to analyze, and we detect this kind of mismatch in DNA gene, and this is a sign of cancer, right? To detect cancer. But let me show you some of our results. So for the very first time, we use this new platform based on carbon nanotube and gold nanoparticles, very high sensitive electrodes to monitor cancer progress, right? So we use, just a TP53 gene. If you are familiar with different cancerous gene, definitely you are. So this is an important early diagnostic cancer marker, and just a tumor suppressor gene, TP53. So it's mutated in most type of human cancer and in breast cancer. And the aggressive growth of several types of just cancer attributed to mutation in this gene. This is a very important gene here. And the challenge here is that for the application of earlier diagnosis, when we want to detect cancer, just in earlier stage, where the analyte concentration is very low, developing a simple, rapid, low-cost, high-sensitive, and selective just platform is challenging and critical subject for TP53 mutation detection. And we address this. How? By developing this very high sensitive electroactive surface area of carbon nanotube and gold nanoparticles, right? And you see the result for the very first time. The detection limit was 0.01 femtomolar, which is, you can imagine this very, just very, very small number. So it's 10 times lower than this detection limit, lower than the lowest reported result at the time. And, just in the media, so definitely, just different media acknowledge this work. So you see, just, this is not the only work that we did. For example, we detected a kind of anti-cancer drug as well in very small quantity by using this methodology and by using this idea that, just if we can develop a sensor sensitive enough so we can detect even a very small amount of this gene mutation in blood, for example, and just we can do a kind of early birth diagnosis, right? That can help hopefully just to at least prevent cancer, right, and save people's life. But if I have time, that I think I have maybe 5 minutes, I want to just show you what's happening now in my lab and what we are working on, right? So you might be familiar with additive manufacturing, but all of you familiar with AI, artificial intelligence, that these days, just a hot topic in the world. So, just additive manufacturing, I have a video to show you here. Right, so additive manufacturing is a novel manufacturing techniques, right? So it can, just print material layer by layer onto the surface. And it's definitely changed the entire manufacturing enterprise by 2030, right? And if you look for this novel technique, you see how flexible it is. It's design flexible, it creates low waste, and it has many advantages, different type of technique. I don't want to go in detail, but I want to show you, just how we are taking advantage of this novel manufacturing technique. So at University of Waterloo, so the people, by combining a prof, Emmanuel Ho, which is my colleague. So by combining 3D printing and nanomedicine, they could combat HIV. And you see, if we take advantage of nanotechnology and additive manufacturing and advanced material, even we can, just do more in terms of just preventing cancer. So let me just show you quickly what is happening now in my lab. So we, just develop a kind of carbon nanotube, again based, just not nanocomposite, but this time by a novel technique, by using additive manufacturing or 3D printing. So we use a novel green, eco-friendly approach. So you see, this is the extruder, this is the 3D printer. We make some filaments, put this filament into the 3D printer, and this is the electrode, right? That I already just talked about, the electrode for biosensor. This is our biosensor, right? But you see, for example, about different weight percentage of carbon nanotube, we make filament and 3D printed parts. This is the percolation threshold. I don't want to go in detail, but look at this. So we do advanced characterization in my lab as well to understand better the material property. So with this technique, novel technique, so we we embedded carbon nanotube inside polymer and then use a surface activation method to expose carbon nanotube to the surface, right? And then we add gold nanoparticle. And then this is a very highly sensitive just biosensor to detect cancer, right? So in the next step we are currently working on, so we want to, just take advantage of 3D printing and just electrochemical sensor, the idea that I told you, and we want to make the, just wireless wearable electrochemical sensor. So look at this picture, for example, imagine if we, for example, have this kind of sensor, which is wearable and miniaturized, and it's only possible with 3D printing, not other techniques. Not only, but 3D printing has a lot of advantages. So you can detect, it's going to connect that remotely wireless to computer, and this is the signal, right? And again, it can help to detect cancer for early cancer diagnosis before go to cure, right? So this is what's happening now in my group. And yeah, so I already talked to my group. So we work on multidisciplinary areas, but the main idea in my group is, just combining low-cost additive manufacturing, nanotechnology, material science background, sustainability, and circular economy to make things happen. For one of the application is, just biosensor, but we have a lot of application that you can see in the video. This is another application that maybe I don't have time to go through. But yeah, so this is, just what's happening now, and hopefully we can, just help the scientists and scientific work to address this challenge, right? Because the stat that I showed you for breast cancer is really shocking, right? And we need to do something about this. So, okay, so I would like to acknowledge my industrial and governmental collaborators in, Canada. But if you, you are interested, so you guys, just work on the, maybe another view on, just breast cancer or different type of cancer. But if you are interested, I'm open to any collaboration, so you can contact me or go to my website, please, through this link that you see here. And I would be happy to maybe take some question if we have time.
Thank you, Dr. Ramona. Thank you for your presentation.
Sure.
If any participant have questions, they can ask now.
Hello, Julie here from Phoenix, Arizona. I'm in the Zenhauser lab. I'm a recent convert to nanobioscience, so I'm working in his lab right now. And I was wondering, when you're doing, like, what is the cost? Do you think the cost is right now in doing research for looking at, especially P53, but what if we had another specific gene that we wanted to look at? Because I'm very interested in, I'm looking at the caveolin-1 gene, but right now it's in early breast cancer, so node 0, and I'm interested in tracking it across as it goes increasing in stage to see if CAV1 is still increasing or plays a different role. So something like, being able to track that with samples would be awesome.
Okay, so thank you, Julie. Very nice to meet you. So yes, so just the cost here, if we use just the so 3D printing. So for the first run of just result that I showed you, so I use the just electrochemical technique, right? Electrochemical synthesis, if you are familiar, because I have a little bit of expertise during my PhD. But just that was an approach to synthesize nanocomposite material to detect, for example, just cancer or DNA hybridization. But I switched to 3D printing. So 3D printing, just it has just different advantages in terms of cost. If you compare, for example, 3D printing with other techniques, for example, with electrochemical techniques to make these electrodes. So one of the, just main features, so it's very cost effective because we use a desktop, just a 3D printer. Maybe you see here, or let me just see this one. This is a 3D printer, for example, just with work. And it's a desktop, so you can even purchase it with $100, right? So, and then with the desktop 3D printer, as long as you can make the filaments, right? So whatever design, for example, this design of biosensor we printed, right? Whatever design you would like, so you can just quickly print, right? And even you can print selectively on different areas of the substrate. So currently we are looking at detecting multi-gene instead of just one singular gene, right? So if you are familiar with the, definitely you are with the gene chip, right? The gene chip, so there are different arrays or different just areas, and it can detect multi-gene if you have not only, for example, the one specific DNA mutation, multi-gene, right? And we are working on this, but it's not possible with any method just except 3D printing, because by 3D printing, we can print in this area and then go in this area and this area, so just easily. And in terms of cost, it's it's very low cost, right, compared to
comparatively, right, to like a array or next gen sequencing. I mean, I don't need, that when I saw this, I just was like, I love this, because
okay, that's perfect.
Like 25, maybe 25 genes. We don't need to spend money for a whole array or sequencing when we know what genes that we're looking for. And we want to track that across different stages across cancer. So this is really interesting. Thank you.
Oh yeah, sure, Julie. So just if you like, so you can send me in chat your email address. So I'm gonna send you an email. We keep in touch in background, because just I'm working with one of my collaborators, Dr. Dario. From the science department, so just his expertise in gene and DNA, just the different strand. So I keep in touch, and then we can discuss more. Definitely, just
Great,
please type in chat your email address.
Thank you so much, Dr. Ramona, for your presentation and also for clearing all our queries.
Thank you, Jill, for just inviting me and providing me this opportunity. I'm very happy that see the scientists here. Julia, I got your email. I'm gonna just let you to the next presenter. Thank you so much.
Thank you so much again. And I would like to call our next presenter, Dr. Beatriz Pinto from Polytechnic Institute of Quevedo and Portugal, to deliver her talk on the perception of breast unit directors of integration of new technologies in breast procedures. Hello, Dr. Pinto. Can you hear me?
Hi, can you hear me?
Yeah, we can hear you. Hi, most welcome.
Can you see my screen?
Yes, we can see your screen as well.
Can I begin?
Yeah, sure.
Okay. So good afternoon to all the present. Firstly, I want to thank the organizing committee for the invitation. It is a pleasure to be here to share some of our results obtained with our research. My name is Beatriz Pinto. I have a degree in finance and a master degree in financial management. I'm a researcher at the 2AI Applied Artificial Intelligence and at SIC Research Center in Accounting and Taxation. Today, I come here to talk to you about a part of our study in which we proceeded to the analysis of the perception of the breast units directors about the integration of the new technologies in breast procedures. This presentation is divided into the following topics. So in the beginning, I will do a first concern about a brief introduction about what I have been doing, what are the steps that I've been taking until we carried out the acceptability analysis. So as I mentioned, our study is under development on the 2AI Applied Artificial Intelligence Laboratory under the OncoNavigator project, in which it is being developed an innovative navigation framework that combines real-time information obtained through ultrasound images with a collaborative medical robots to give a greater precision to the current breast cancer interventions, namely biopsies, ensuring a safe, fast, and easier to perform breast biopsy procedure. Within this project, and considering my background in management and finance, we began by investigating the care cycle that is associated with the medical procedures that a patient has to go through or is advised to go through, from screening to treatment and subsequent follow-up, which resulted in the development of a flowchart that illustrated the interaction between these different procedures depending on the patient's characteristics, the genetic characteristics, and the diagnosis phase, among others. Here we present a very simplified version of the flowchart that was later published in the journal Proceeding Computer Science, the results that we have achieved through this analysis. With the accomplishment of this research, we observed that one of the existing opportunities for the integration of the new technologies to optimize the care cycle in the case of a breast tumor was centered in the diagnosis phase. Because if the diagnosis obtained is as precise as it's possible, then the procedures after is going to be as well as important. So, as we all know, and we have been talking about the introduction of artificial intelligence and robotics in health as being helpful, but in the introduction of these new technologies in biopsy procedures have enabled them to achieve a greater precision and stability, real-time image feedback, among other advantages. However, this introduction has been accompanied by some disadvantages as well, such as the increase in the costs related to the acquisition of these new technologies, that sometimes they are a little bit expensive, the need to adapt to the new technologies by the radiologists, among others. Taking into account the constant evolution of the technologies, as well as the increased integration of them in the different areas of health, it has become imperative to study the acceptability of health professionals regarding the integration and application of AI and robotics in health, as well as the possible drivers of this integration. Some of the state-of-the-art that already exists regarding the health professionals' acceptability of the integration of new technologies include the study that was conducted by Mason, where it was found that most respondents of the survey that they conducted showed a positive attitude towards the applications of artificial intelligence in health. In addition, they showed high expectations regarding the potential of AI to support decision-making, especially in areas of intervention that involve the treatment of large amounts of data, such as radiology and pathology. In another study conducted by Chen, they also, et al., 2022, they also achieved similar results, since in the service that they performed to physicians and medical students, they observed a positive attitude regarding the integration of AI in clinical practices, and also the presence of intention to use it. However, they identified some exceptions highlighted by the inquiries that included the unpredictability of results provided by AI, the errors that were associated with it, the possible increase in the dependence of the clinicians on AI, the lack of empathy, and other concerns. In general, the inquiries showed some positive attitude towards this integration, that they were open to it, as long as this did not affect the safety of their job. The other authors conducted a study about the drivers, that was Raimo and Tortorella. Raimo et al. 2023 analyzed the drivers of digital transformation in hospitals located in Italy. And in this analysis, they concluded that the size measured by the number of beds, age, and teaching status that was affiliated if the Institute was affiliated with another university were the drivers with the positive and statistical relevant impact on the digital transformation of the Italian hospitals. Only the number of hospital departments did not show a statistically significant relationship. On the other end, Tortorella et al. 2020 carried out the study of the 5 contingency factors: hospital ownership, age, number of employees, number of inpatient beds, and functionality in the implementation of health technologies in healthcare. They evaluated 16 hospitals located in Brazil, Mexico, India, and Argentina, and concluded that the functionality and ownership of the hospital are important drivers in the implementation of the new technologies in health. Regarding the age of institution, the authors observed that if the health unit is older, that is, if has more years of existence, there is a greater resistance to change because there are some barriers in learning the use of new technologies. Therefore, according to the results obtained, the authors concluded that the age may have an inverse impact on the adherence to the technology. That is, if the health institution is younger, the greater are the probability to this adherence occur. Concerning the size of the health unit, they couldn't get to a point because the results achieved were controversial since number of beds and professionals shown different results. Based on the review articles, we defined the following research objective, that it was to understand the attitude of the specialists regarding the integration of artificial intelligence and robotics in breast procedures. And to achieve this objective, we conducted interviews and a survey by questionnaire to the clinical directors of breast units in Europe. As I mentioned before, first we conducted 3 interviews with clinical breast unit directors located in the northern region of Portugal in order to first corroborate and improve the flowcharts developed that I mentioned in the beginning of the presentation. And after, we tried to initially understand what were the difficulties that they felt during the execution of the breast biopsy procedures, and after understand what were their opinion about the integration of these new technologies in such procedures. In addition to the interviews, we applied a survey that was sent to an initial sample composed by 182 breast units from 29 countries in Europe that were registered in the breast centers network. Here it's possible to see how the initial sample was composed in terms of breast units in each country. As you can see, Italy was the country with more breast units registered in the breast centers network, representing 28.56% of the initial sample. The survey was available in the period of June until March of this year, and during that time frame, we got 9.89% of response rate, equivalent to 18 valid responses. For the application of these interviews and survey, we got the following results. Although the interviewees shared some characteristics such as the close proximity of the breast units' years of existence, the slight difference in years of experience between E1 and E3, and the shared specialty of E2 and E3, the perceived challenges and opinions expressed by each interview varied. All of the interviewers claimed that they didn't have difficulties to perform the fine needle aspiration biopsy and core needle biopsy guided through ultrasound. Sorry. But, however, they identified that the execution of the biopsy techniques guided through stereotactic and magnetic resonance had a greater level of difficulty, especially the last one. Additionally, the second interview mentioned that the format of presentation of the current images was also difficult, since when it's performing any breast procedure, what it's been seeing is presented in the format of 3D instead of the 2D, that is the images that are provided to the physician whilst doing the procedure. The fourth interviewee added that one of the difficulties felt was related with the selection of the most appropriate imaging guided to proceed to the execution of the biopsy procedure. Regarding their opinion about the integration of the technology in the breast procedures, once again, it was possible to observe a divergence of opinions, since E1 showed a negative opinion about the integration of these new technologies, because E1 mentioned that he didn't saw the interest to integrate the new technologies in the breast biopsy procedures, but in the end, after thinking a little bit more, he ended up mentioning that probably it would be interesting if the integration of these new technologies could generalize the execution of the biopsies guided mostly by guided magnetic resonance, because here in Portugal, he mentioned that isn't produced or executed by many physicians, and there are a few health institutions that provide this kind of biopsy guided through magnetic resonance. The second interviewee showed a positive attitude towards this integration, in the sense that he too demonstrated interest in the introduction of the lesion segmentation softwares, even though it already exists some softwares, but the interview mentioned that the already existing softwares aren't easy to access and they are expensive. About the robotic integration, Itu mentioned that it was something that it sees happening, but not in the short term, at least not at an accessible price. The fourth interviewee also shown a positive attitude, as it visualized an added value in the use of the new technologies, such as robotics and artificial intelligence in these procedures. However, he has some experience in the health economic sector. So he mentioned that in order to have a base to make a decision, he will need to consider all the costs and gains that are involved in this decision. Before presenting the results that we achieved through the service, let me just present some sociodemographic characteristics. As it is possible to see, our 50% of our sample was correspondent to physicians with the age between 55 and 64 years old. Regarding the country of the inquiries, considering the composition of the initial sample, it was normal to see that 22.2% of the respondents were from institutions located in Italy, followed by respondents from Portugal, Belgium, Netherlands, and Turkey. From the perspective of the survey respondents, to achieve their opinion regarding the introduction of these new technologies in breast procedures, we used an open-ended question. And the responses that we achieved through those questions were grouped into 3 categories. Positive, in which we included answers like favorable, and I certainly like it to try. It's an interesting idea. I would like to try it. And negative, which included answers like it's not very useful, it's superfluous, I don't think it's necessary. And neutral, that it was the third category, in which included answers like I don't have opinion, I don't know, or their opinion would depend on the goals of the robots and how the technology would work. After analyzing the responses, we discovered that 38.9% of respondents had a favorable attitude about integrating new technology, and 16.70% had a negative view. The remaining had a neutral attitude. When analyzing the age of respondents with a positive attitude in relation to the drivers of technological integration, we found that almost 50% of the respondents were under the age of 54. Regarding the respondents' years of experience, more than half of those who showed a favorable attitude regarding the use of robots in breast interventions and up to 24 years of experience, and all of the respondents that showed a negative attitude have been working for between 27 and 30 years old. These findings were in contrast with the ones received from the interviews, since the interviewee that had more years of experience and age was the one that showed also a negative attitude. Finally, in terms of the age of the breast units, we found that among the respondents who had a positive attitude, about 50% belonged to units that had been founded more recently, specifically since 2010. The remaining was split in half and were found between 2005 and 2009 and had been founded before 2005. These findings were in line with what was mentioned by Raimo, and in the terms that if a unit has more years of experience, there can be some greater resistance to change because there are some barriers in terms of learning the use of the new technologies. So, talking a little bit about the conclusions, through the results obtained, we understood that almost half of the specialists, either the interviewees and the respondents, showed that they had a positive attitude towards such integration, since they saw the new technologies as a favorable asset to support the execution of breast biopsies, especially the biopsies guided through stereotactic and magnetic resonance. About 20% of the specialists showed a negative attitude about the possible innovation drivers. With the data that we collected, we could deduce that a specialist's propensity to accept the new technologies could be influenced by both age and years of experience of the specialist, and the same can be shown in relation to the years of foundation and typology of the breast units. The results achieved were in accordance to the findings obtained in the studies conducted by Raimo et al. And Tortorella et al. But in terms of the attitude, we couldn't get the same results as the Mason and Chen could, because in their studies they experienced that most of their inquiries showed a positive attitude, and in this study we couldn't achieve those results. Here are some bibliographic references that we used during our presentation. Thank you. This is how you can email me if you want. Do you have any questions? I am open to questions.
Thank you, Dr. Pinto, for your presentation. I hope all of the participants might have enjoyed that. And yes, if there are any questions, they can go on and ask. In that case, if there are no questions, I would like to go to our next presentation. Thank you once again for presenting.
Thank you.
Yeah, now I'd like to call upon Dr. Laila Sheikh Nizar from Tabriz University of Medical Sciences, Iran, to deliver her talk on blaming in women with breast cancer subjected to intimate partner violence, phenomenological study. Are you there, Dr. Laila? Dr. Laila, can you hear me?
Hello.
Yes, Dr. Laila, hi, most welcome.
Can I begin?
Yes, sure. You can start your presentation.
And you see my screen?
Yes, we can see your screen.
Okay. Good day, everyone. Let me briefly introduce myself. My name is Leila Sheikh Nejad from Tabriz University of Medical Sciences in Iran. And I'm delighted to be here today to talk to you about my latest study entitled Blaming in Women, a Hermeneutic Phenomenological Study. My presentation is divided into 4 parts. I start with background and problem statement, then I will look at the methods of the study, next the result of the study, and finally I will present the discussion and conclusion. As you can see on the screen, breast cancer was the most prevalent in cancer throughout the worldwide until 2022. A cancer diagnosis is turning point in patients and their families' lives. It can cause familial conflict and lead to social, economic, and emotional consequences. Evidence show that being diagnosed with cancer makes women prone to harassment. Following the disease and surgery and chemotherapy, potentially paving the way for IPV. According to WHO definition, IPV refers to any behavior within an intimate relationship that causes physical, psychological, or sexual harm to those in the relationship. Studies shows that chronic disease of one partner is among the factors leading to IPV. Among women's cancer, due to role of the breast in femininity and breast function, breast cancer is the great significance due to its effect on sexual relation and sexuality. On the other hand, these women have problem in their familial relationship during treatment due to a lack of energy. This factor lead to a higher chance of experiencing IPV compared with other cancers. The prevalence of IPV among Iranian breast cancer women was reported 90%. Another important point is evidence shows that some patients with cancer may suffer from stigma, shame, depression, anxiety, and anger. Internalization of stigma leads to blaming. Blaming is a less adaptive strategy that women diagnosed with breast cancer may use. Patients may blame themselves or others for their cancer. Self-blame in patients with breast cancer has 2 types: behavior that results from behavior such as smoking due to lung cancer, and characterological self-blame that results from personal traits that cannot be changed. Based on evidence, blaming is the complex mechanism which is used by women with breast cancer to adjust with their disease and treatment. There are different quantitative and qualitative essence of blaming in breast cancer women with abusive partner is not still clear. Therefore, we decided to explore lived experiences of breast cancer women subjected to IPV about blaming. The research question in this study was, what are the lived experiences of women with breast cancer subjected to IPV about blaming? Let me draw your attention to methods of the study. 6 steps of Van Manen's hermeneutic phenomenological methods were used to explore blaming, which is a multidimensional and complex context that depends on context, personality, and culture. Using hermeneutic phenomenological provides deeper insight into gender and victimology researchers. The study setting was Oncology Hospital of Tabriz. Tabriz has the largest oncology center in Northwest Iran. Participants were selected using purposive sampling. Inclusion criteria was women with breast cancer who were living with their partner at time of the cancer diagnosis. All participants were aware of their cancer diagnosis and with at least 6 months since their cancer diagnosis. The initial interviews were conducted to identify women exposed to IPV based on question of the abuse assessment scale. And then we invited the eligible women to participate in the study after explaining study subject and receiving written consent. The semi-structured individual in-depth face-to-face interviews were conducted at place where the participants were comfortable. In this table, you can see the participants' demographic information. 9 women with breast cancer aged 40 to 60 with a mean age of 47.5 years were recruited into the study. No limitation in the incidence, age, and grade of cancer was considered. The participants were on average in abusive relationship for 23.5 years. The data were analyzed using a holistic and selective approach of women and thematic analysis. Based on holistic approach, interview text was reviewed several times and overall meaning of the text was considered. Through selective approach, thematic statement that appeared in the text to illuminate the essence of phenomena were selected. Formulated statements were then categorized, leading to the extraction of themes and subthemes. This process continued until the main themes hidden in the lead stories of the participants emerged. The findings were provided to the participants to receive the feedback. To strengthen the rigor of study, GOBA's criteria, including credibility, confirmability, dependability, and transferability, using prolonged engagement, trust-based communication with the participant, external audit documentation, and etc., were applied. Turning your attention now to results that got. If you look at this table, you can see that one main theme with 3 subthemes were identified. Blaming as a shift in cognitive judgment, which included subthemes of patient blaming partner, partner blaming patients, and self-blame. The participant experiences show that living with an abusive partner and suffering from cancer puts a lot of psychological pressure on this population of women, which leads to shift their cognitive judgment to blaming. These results are described by quotations at next slide. Subtheme patients blaming partner. According to participants' experiences, women who have lived with abusive partner for years believe that psychological pressures and stress resulting from the development of their breast cancer. For instance, one participant said he did not care about anything, food, clothing, the future. From the day we started our life together, I lead a stressful life. Stress made me ill. Partner blaming patient subthemes. In some cases, participant reported that their partner blamed them and told them that their behaviors such as idealism, tendency to help others, obsessive behavior, and unnecessary stress had led to their current condition. One participant's experiences is that he always tell me I'm obsessive and I have cancer because I stay in the water a lot. He blames me and tell me children to bring me food separately because I have cancer. Subtheme self-blame. it seems that women who live with partners who blame them for a long time are affected by their suggestion and gradually accept that they have played an indirect role in the development of their disease. Consequently, they feel guilty and blame themselves for their partner abusive behavior and blaming. One participant says, I keep thinking if we had not talked about my previous lover before we got married, he would not have become so suspicious and annoyed me so much that I would get cancer. If I had gotten divorced when I left he and went back to my mother's, and if I hadn't tolerated him because of my children, I would be healthy now. Please have a look at this figure and let me summarize briefly the connection between sub-themes. After the occurrence of mutual blame, the participants experienced a feeling of guilt in the first stage. The psychological and physical decline resulting from cancer treatment, additional cost imposes on their partner, and some behaviors such as being timid and or not being able to stand up to their partner violence are factors that they mention as leading to IPV. In the next stage, these women accepted that their partner's misbehavior is associated with their personality traits or physical and psychological changes. As a result, they felt frustration. To return to our original question of the study, that was what are the lived experiences of women with breast cancer about blaming. Our results show that they experience blaming as a shifting cognitive judgment in three forms of patient blaming, partner blaming, patient and self-blame. In this line, some studies show that psychological adjustment to threatening life events such as confronting breast cancer and a study showed that women diagnosed with breast cancer reported more frequent use of maladaptive cognitive emotion regulation strategies such as self-blame and blaming others, which can lead to maladaptive behavior and are not conducive to patients' rehabilitation. When couples try to cope with the stressors associated with cancer, they may suffer from latent blaming, which can threaten their psychological adjustment and increase their distress. Blaming led to higher distress in those who experienced lower dietic adjustment. In this condition, anxious couples reach a dead end in their interaction, and mutual blaming and accusation occur in couples who experience a higher level of distress. The result of previous studies shows that naturally in stressful situations, people tend to unconsciously look for the reasons to reduce their fear and uncertainty. The most common question asked in this stage is, why me? In this stage, patients start looking for reasons and might blame themselves or others for what has happened to them. Chen et al. Claim that there is a direct relationship between the stressful event and cancer development. However, some researchers claim that there is no relationship between chronic stress and breast cancer. Also, connection between women's personality traits and incidence of breast cancer, it is contradictory. The result of several studies confirm this relationship. However, some studies have rejected the relationship between personality traits and cancer. The finding indicates that blaming patients disrupt their self-concept. Patients with breast cancer usually experience a negative self-concept because they may think they have lost their familial roles as women and cannot take care of their family. One of the most common, and they tend to blame themselves. Standing up women with breast cancer may feel guilty when diagnosis or even year after it. Feeling guilty can lead to frustration, loss of control, and sorrow in cancer patients. Finding of the current study confirmed this feeling. And other study supported these findings. Frustration can be due to the numerous reasons such as unmet needs, fear of failure in treatment, and low quality of life. Pocock et al. Chance that some women don't live an abusive relationship because they blame themselves for their partner, insulting behavior, blame. In conclusion, let me sum up my main points. Women with breast cancer who are simultaneously subjected to partner violence undergo changes in cognitive judgments that could lead to experiences of partner mutual blaming and the patient's self-blame. Blaming oneself or others for a disease can have adverse psychological effects on patients and partners' interaction. Therefore, vulnerable people such as breast cancer women experiencing IPV or those with life-threatening condition and their partner must be identified as soon as possible and provided with psychological services to be able to cope with stressful situations. Due to significance of the breasts and their function in intimate and romantic relationship of couples, providing couple-centered and patient-centered care instead of disease-centered care is necessary in planning intervention programs for patients with breast cancer, especially those who felt trapped in an abusive relationship. Effective cancer management is achieved when a multidisciplinary team exists. Also, due to the knowledge gap regarding the role of chronic stress in the development of cancer, more extensive studies are needed to enable healthcare healthcare providers to support patients with cancer and their families by comprehensive preventive intervention. Thank you all for listening. I'm happy to answer your question now. Do you have any question?
Thank you for your presentation, Dr. Leila.
You're welcome.
If any participants have any questions, they can ask. In case there is no questions, we move to the next presenter. I call upon Dr. Ildefonso, Pan-African University, Kenya, to deliver his talk on new test for the comparison of survival curves to detect late differences. Hello, Dr. Ildefonso. Can you hear me?
Yes, hello. Good evening.
Yes, doctor, please continue.
Okay, thank you so much. Let me see. Okay, I'm sharing my Do you see my screen?
Yes, doctor, please.
Okay, thank you so much. I'm Nizeyimana Ildefonse. I'm a PhD candidate at Pan African University in statistics. Our work is about a new test that we proposed for the comparison of survival curves to detect late differences. For the background, you know that usually our work is about survival analysis, and it has many applications in engineering, medicine, and even social sciences. And of course, here our work is in its application in medicine. And then in survival analysis, it is about the clinical trials as we are interested in breast cancer and women cancers in general. Here it is our work is about the comparison of treatments. The treatment you see when, for example, when you are treating cancer, you can just categorize the sick people in a group into treatments and let them undergo different treatments. So this is what we are dealing with. Our work, this is what it is about. And then you deal with the survival curves of the respective treatments. And then the weighted log length test is the test that we were working on. We were bringing the improvement on it. We're bringing the improvement on the weighted log length test that I will be showing you. And there we can see here that we may be dealing with, for example, the time of tool emission or recurrence of the tumor or even the death of the person, things like so on. Those are the events of interest usually. When we are considering the comparison of treatments, those are the most of the time. It is either the time of death, the recurrence, time of tool recurrence, or time of tool emission. Such events of interest, most of the studies, those are the ones of the events of interest. And then here again, we refer to the censoring because in the survival analysis, it is like the threat, it is both the threat and the threat and the characteristics somehow. Yeah, censoring like lost to follow-up. See, people may have been in the study and be drawn or be lost to follow-up, or the study can end just without this undergoing the event of interest. This is what the censoring is about. And then the problem that was there that we managed to dealing with, it is that in that weighted log rank tests, on all the existing tests were just exploring only the here, for example, you see this is the risk, individuals at risk. This is the quantity called the weight, and that quantity was just in function of this quantity called the number of individuals at risk in general in the two groups. For example, let's assume that is the two groups or two treatments that are being considered. So here in our case, we tried to see if we put the separate numbers at risk, we see this R1 and the R2, if we include the separate numbers to define the weight, can we probably get a more sensitive test in a specific scenario? This is what we were proposing. Then the objective, of course, it was to propose a new weight function which with more parameters. Why? Because if they used to be dealing with this or its function, then with this we see we will be including more parameters, more two parameters, R1 and R2, whose sum make up this one. Then with that new weight function, just we are hoping to get a more sensitive test. Of course, a more sensitive test of any test is sensitive in some scenario, not all. This is how it works. And then the Kaplan-Meier estimates, it is a quantity of crucial interest. It is an estimate of probability. It is also called this quantity is called the, sorry. This quantity is called the product limit formula. Product limit formula, this formula, for those who are not statisticians or mathematicians, this quantities, it says it stands for product, this quantity. This means like the product for any tj less than a specified time t here, for it to mean the survival, the number who are still surviving, the ST means the number of people who are surviving until time t. Then it is known, it is computed like this. It is the multiplication or the product of all those quantities t times 0, from time 0 up to time t. This is 1 minus dj over rj. Rj first, it is the number of individuals at risk or who are still alive at the time of tj. Then dj is the number of individuals or items who just underwent. Even though here I've said the who died, but it depends who underwent the event of interest until that time. This is dj. This is what it means. Then this formula is of crucial role because it has been exploited differently by different researchers or biostatisticians. Then usually there is the hypothesis that is being tested. The test of hypothesis or the hypothesis that is being dealt with is the equality of survival in 2 treatments. If the people have been in 2 treatments or have been just submitted to 2 treatments or randomized into 2 groups, then we are saying the survival, the survival in one group is likely the same or near the same like in the 2 groups. The survival probabilities at any time is equal to is the same in all the 2 groups. But or the alternative hypothesis is that one group may be or either with higher survival probability than another, or either it may be, or of course in a just or in all time points, but it may be also in some time points. Let me say this is why, because if this is for all time, then this may be not verified for some time, not necessarily all time. Then this is the stochastic form of the weighted log-rank test that we are dealing with. This is the test this is the existing formula of the test that we are dealing with, and our task is about bringing a new function, this WT. This WT is called the weight function. This weight function helps us to shape a test which can help to be strong just in some scenario. Why? Usually we know that when we are dealing with, for example, breast cancer or any type of cancer, some tests, some studies, some clinical studies, you may see some differences rate just occur in the long run. Let me say, you can see the difference in the long run. So those weight can be built. Those WT, of course, are of crucial role because they help to give this test or this statistic, sorry, to be more powerful in specific scenario than others. Then the construction of this weight is of crucial role, and this test, depending on how WT is defined, the corresponding variance is this one. And then, of course, when you can go back, when you come here, this is the number of individuals at risk in group 1, here in group 2. Then this is the overall. This RT with no index, it is the sum of those 1. This is the separate number of individuals in the 2 respective groups. Then NT is the number who underwent the event of interest. If it is remission, if it is the recurrence of the tumor, for example, things like that. This is NI, or this one N1 and N2. It is the number of individuals who have undergone the event of interest in group 1, here in group 2, respectively. Then this was the same that we're dealing. Anything in general means the sum of the 2 of the two in the two group of the total number of individuals who underwent the event of interest. The same is used here only, but yet is the separate numbers who underwent the event of interest, but this and the total is just used in the variance. Then, okay, with this, it is when we go in the computational form, because when we are evaluating the statistic, we use the computational form. That previous form is the stochastic form. This is the computational form. This is WJ. Here it is the weight at the time TJ. This WJ, it is the weight. This is the people or the number of individuals who underwent the event of interest at time J from group I. I is the number, is the group. I stand for the group. J stand for the time. Then for this is DIJ, it is the individuals who underwent the event of interest from group I at time J or TJ. This J stands for time. Then this TJ is the number of individuals who underwent the event of interest in all groups. In all groups, here it is in one group I. Then here it is in all group at that same time. Time it is TJ. This RJ, it is the individual. The number of individuals at risk in the group I at the time J. Then this is the number of individuals at risk in general in both groups under consideration. Then we sum up. This is the statistic computationally that will be using when we will be evaluating the power of our statistic. Then its variance is of this form. And then when we use the statistic, whose expected value is 0, and the variance is this one, we will find it's chi square or chi square. Yes, the variance u over value is the chi square distributed with this form in the equation 5. Say a chi square distributed statistic that u squared, this is u, see, this is u squared over that variance. Then this is a chi square distribution with degrees of freedom 1. And then when you put the square root on both, on the denominator and the numerator, you will obtain that it is asymptotically normal or asymptotically normally distributed. When it will be an asymptotically normal test, if you want. This statistic will be asymptotically normal with, of course, mean 0 and variance 1. It will be a standard normal distribution. Then the condition on the weight function is that the weight function must always be positive and finite. Those are the conditions, only conditions on the weight function. The weight function is only just is not allowed to be negative. Simply, it is the prohibition on the weight function. Then those are some of the famous weight functions that which have been hugely exploited. But is not all. It is just some, as we highlighted. This is mainly this family of Fleming-Harrington is the one which has been hugely exploited with this rho and gamma. This is the powers here which are dealt with. The manipulation of those one help to get the different scenario that we may be exporting. The manipulation of those rho, those two parameters, rho and gamma. You can manipulate them, can be 0, 1, but just 2, 3, 4, anytime, just depending on the form that you want that weight to have. And then when we went to the proposed weight in our study, we proposed the weight of this form. This is a decreasing one. We call this, of course, the form of our test. It has been exploited in one way, but the fact that we include this stuff, we will see up to now, we are with some hope that this involvement of these two quantities, the separate numbers of individuals at risk in the two groups, will make it more powerful in some more circumstances. So let's say, yeah, this is the hope that we're working with. Then this is the weight that we proposed, and then the stochastic form of the newly obtained statistic was this one. And the corresponding variance is this one. Then with the stochastic, because there has not been exploited hugely, we went to the computational form of that test. This is the WT, and this is WT squared on the variance, of course. This is the chi-square test, of course, but you can simplify it. This one, we square this, we simplify it, and this has been equality there. This is the simplification. This one, this equation 11 is just the simplification of the equation 10. And then this is when we compare, just to be sure that what we did, we compared it by using this formula about the relative efficiency of a test when compared to another. This test, this is the quantile function of the standard normal distribution, and alpha is 0.05. This is the relative efficiency of the test statistic with weight L or the weight W when compared to the one with weight L. Then this quantity will help us to know if the test is relatively somehow powerful in terms of when compared to another. And most of them will compare with the standard log-rank test, whose weight is 1. And then those are the data that we get, the results. Those are the results from the simulation. You see, this column is for our newly proposed test. Then, because it is for data difference, to avoid the confusion, all that's the ones we will simply just exploring the other test. But the test of interest that we will be comparing with is this one, FH01. It is from that family that I was saying, that I mentioned, Fleming-Harrington. This is Fleming-Harrington 01. Rho is equal to 20, and the gamma is equal to 1. This test is the one which is powerful for the detection of rate differences. This is the existing test. Then this is our new one. This is the first one to be powerful in normal conditions, unless there is some particularities. And then this table here, it is N1, N2. This is the number of individuals in group 1 or the sample size, let's say. This is the sample size in group 1 and the group 2 respectively, and the sample size are equal in the two groups. It is the simulation, and the number in the parentheses are the censoring. Then here it is, with no censoring, with censoring of 20%, censoring of 40%, and censoring of 60%. Then for any sample size, we took the same proportions of censoring to evaluate the performance of the test under consideration. But our focus will be on the comparison of this existing powerful test for the rate differences and our new test. The observation has been that our new test is like a secondary alternative, but the difference is not that much. But when we reach to this, you see here for the sample size of 50-50 in the two group up to since now, here you can see that from here and here, our test become powerful. Our newly proposed test can be a good alternative according to when compared to the already existing test. You see, for the sample size of 100, the existing test was still powerful. Our test would not be just somehow recommendable. But when we reach to the sample size of 50, for example, you see here, then our test has been the most powerful when compared to the existing powerful test. Others, we will not talk about others because others are not usually good alternatives for the detection of the late differences. And then, since 50%, from no censoring and all type of the censoring, our test will remain powerful. When you compare this column from here up to downward, and from here, you will see that when you compare just row by row, the two tests, we find that our test has been a good alternative since the sample size is equal to 50. Then we will finally get that for the small sample size and heavy censoring. You see, for example, this one, this extreme case, you say heavy censoring, it may be a good alternative. But you know that simulation can be not reliable unless we apply any newly proposed technique to real data. Then this is the first graph of those data. This is of those data has been put here just to be visualized digitally. For example, this is the test, the powerful test is this first one here. And this is our test that we proposed. You see that here they may be like the same, but with small, this was still like somehow powerful. But when we reach here, for example, at 50, this is at 50. You see that this is higher than this one. Can you see? I think someone can see if you see clearly here. This one is our test. This new test is powerful, more powerful than this one. It is just the same like those one. It is the data, the result from the table, previous table that we put here on the graph to make it easily detectable. Yeah, this you see this is with no censoring. You see here with no censoring. The first case is with no censoring. With censoring equal to 20. With censoring equal to 40. Then with censoring equal to 60%. Of course. This is how the flow. You see that all the colors, the order of the colors keep the same. With no censoring is better. With little censoring of 20% at least. With censoring of 40%, the power reduces, and with censoring of 60%, it becomes worse or relatively worse. Then, this is the comparison of the heat map for the relative efficiencies of the test compared to the log-rank test. The log-rank test is the standard test that we used to compare to. Then you see that the existing test, Fleming-Garrington test 101, and the new one, the body one, there's one who are darker. You see the relative efficiency. The ones with those two tests are the best, of course. Then ours and the existing one, you see that there is some more differences. You see, for example, let's take this extreme case. You see that our test is relatively better than the existing one. You see, still here is small. But for example, come here again. You see on the no censoring on 100. You see that the existing one was the best, as we have seen. Just is only for the visualization of our data, and I think the deduction is the same one. And I thought too much on the table. Then we applied the new test to the real data just to be sure that the result from the simulation are not misleading, being just that from the EDO simulation of the EDO case. To check the reliability of the new test, we preferred using two real data sets to be sure of the comparison. And those are the neck and the head and the neck cancer study by the Northern Oncology Group. And that is the time to infection of the kidney dialysis patient data. The data from the neck and the head and the neck cancer study, which was done by Northern Oncology Group, are found in the EFRON. The study and has been used by many authors, including this one who used them recently. And the arm A, one arm represent the patient who underwent radiation therapy, and those who underwent radiation as chemotherapy were put in arm B. You see, there was only the radiation therapy and then radiation plus chemotherapy. And then for the second data set, the infection of kidney dialysis patient, it is a built-in data set in R. And then those are how they see. You see, those are the survival probabilities. When you see from time zero, survival probability is equal to 1. But as time elapses, as events of interest occur and censoring occur, the survival probability decreases. This is original. This is the general shape of the survival probability. Then, when we applied the two-real data set, here the interpretation or the results, the interpretation of the results here, it is the p-values that you see. It is not like those powers. Okay, meanwhile, when we are here, can you just first comment on about I was saying about the power. The power of a test statistic. It is the probability or its strength of correctly rejecting the false null hypothesis. I repeat, probably because I think many of you may not be from the statistic background. The power of a test statistic is its power of rejecting truly or rejecting the false hypothesis. If the hypothesis is false, it must be rejected, of course. Then it happens that a test may not be strong, and then not fail to reject it. Then if a test is stronger enough to know to detect the first null hypothesis and reject it correctly as it is deserved, that this is the strength or this is the power of the test. Then here, when it comes to the real data application, we see that here the small number, the smaller the p-value, the stronger the test. This is how it is. This is the p-value. It's different from the real, from the simulation. The smaller here, the smaller the p-value, you know that is the p-value is the smaller, we reject the H0, then, or the new hypothesis. So this is why the smaller the p-value, the stronger the test. For example, when we see here, we can see that our test is the best. For example, we can compare with this. This is our test, which would be the best. Then for the head and the neck cancer data, our test has been the first. It outperformed the existing test. And then when we come to the kidney dialysis patients, it has been outperformed and it can be justified. You see, our test has been powerful, of course, but not the first as it has been. And the justification is that when you see here, this is our case, you see that here there is some deviation because the deviation becomes the separation of the curves start early. This is why even in the test, which is stronger in this test, usually, for example, this test is stronger to detect the middle differences or the middle separation. You see that in the middle of the study, the separation had started. But here, this is why here and here it is somehow different, because see here the cover somehow closer and separate continually, but here they immediately separated somehow is bitterly, if I can say. This is why in our result, even this test, which is good to detect middle differences, it has been powerful. And this, it has been powerful, but not relatively the most powerful. This is why that case, in the first case, in this case, our test has been good, but yet it has been powerful to detect the differences, but not the first. This is why the real application, you can see and you understand the concept and understand how why the results obtained are in that way. And so this is what we have obtained. It is done from here, because I can even just from here we can deduct or get the conclusion that the test that has been newly proposed can be a good alternative or a good choice, or in addition to the existing test, which mainly like this one for the rate differences detection between the survival curves. When people have been randomized, have been put into randomized trials, and then we are expecting the rate differences yes, between the treatments. Either we can use this test or this one. And this our newly proposed test can be a good alternative when we have small sample size and if there are heavy censorings. This is the comments that we were saying from the table, and it is the same with that. We're saying that from the sample size of 100, it was the existing test was good, but when it went to the sample size of 20 and heavy censoring, our test has been relatively better. This compared to this, our test had this relative efficiency, and then it has been good, even though in the case of 100 more good sample size, higher sample size, our test was not or could not be recommended. When it comes to small sample size, it could be recommended. So, and we know that in all the statistical research, the sample size is of crucial role. Then is our test, since our test can be just adaptable and be powerful in this case of small sample size, then we can recommend it. And again, this because even the censoring being a threat, censoring is a threat in such survival analysis or even in clinical studies, then we can recommend our test as a good alternative in both those cases, when there is sample size, small sample sizes, and or the heavy censoring. So, and of course, we have seen that in the same deduction from the simulation results are coherent and compatible with the ones from the real data application. So, the conclusion, the newly proposed test is a good alternative for the detection of rate differences between survival curves. Even though the reduction of power as the censoring rate increase is common, this reduction is relatively small for the new test compared to the remaining others, including log-rank test and the Fleming-Harrington test, the one which was powerful in our situation that we were comparing ourselves to. This was like our reference to see what we are bringing in, like new or like improvement, let's say. The new test may therefore be the first choice in case of small sample sizes and heavy censoring rates. The same strength has been observed while dealing with real data sets when the new test remains still sensitive for rate differences in survival. Then, based on the fact that the small sample size and censoring are the major challenges in clinical trials, referring to the power and the higher relative efficiency of the new test in such cases, one may consider it as a better choice or alternative for rate differences detection between survival curves. Then our recommendation is that as our test, as we have seen from the problem statement, is that as our test got that strength from bringing into the separate numbers of individuals at risk. So the inclusion of separate numbers of individuals at risk is in the respective groups in the construction of weight functions may lead to more sensitive tests in some circumstances, just of course, depending on how the tests have been modified or built. And therefore, more forms are recommended to be explored, including the transformation of the newly proposed weight function. And since during the comparison of some more cancer treatments, just like in other drugs evaluation studies, the difference may occur in the long run. The proposed test in the study can be a good alternative for biostatisticians, especially in the case of heavy censoring and or some small sample size. And then biostatisticians whose interest is in women cancers and cancer research in general can propose more sophisticated tests since cancer evolution goes with other competing risks and again passes through various statuses which might be of interest. Yeah, from this test, you see you can get, because as we're saying about the event of interest, a cancer may, a patient with cancer can be dealing with other competing risks. So in that case, we recommend that biostatisticians can evaluate, can elaborate or suggest or explore many more sophisticated tests just to be, which may be more adaptive in such situations, to be more, so that the results from the statistical analysis may be more accurate. And then our work has been published, and its address where you can find it is this one. It has been published in this March. So this is the reference, and we thank you for your attention.
Thank you, Dr. Elifons. Thank you for your presentation.
Thank you too.
Any questions regarding this presentation? Okay, with that, I would like to end today's session. Thank you for your precious time for our virtual session and having me as a moderator for this great session. I hope you all enjoyed. We are successfully completed today's session, and we will send all certificates to participants through email. Thank you and have a great day.
Thank you.
Thank you.
Okay, thank you. Thank you.
Thank you, everyone.
Sir, thank you too. Goodbye.